Hi, my name is Emily, and I'm really looking forward to presenting to you all today. Introducing my topic. So I'm going to be looking at investigating the relationship between resilience and associated factors in adolescents in an international school in the United Arab Emirates. And this will be a cross-sectional study. So I'm from South Africa, but based in the UAE at the moment. And I work in an international school as a school counselor. And my wonderful supervisor is Professor Bronwyn Kutsia from Stellenbosch, where I'm registered. So today I'm just going to be taking you through a bit of a journey through my research project, and I'm really looking forward to sharing this with you today. And you can have an idea there of just the outline of what I'm going to be covering with you. So when looking at resilience and adolescence, resilience is a really key construct when considering the life stage of adolescence. So adolescence is the stage between childhood and adulthood. So resilience is a really important part of this stage because it's really a phase where children learn more independence, they're forming their own identity, and they're learning how to face more of life's stresses on their own, with the support around them. In the UAE, when doing some research, it's very evident that there is an absence of research in this area, especially with adolescents. So that's part of the reason why I wanted to research this specifically in this context. And it can really inform how schools and parents support their children. So looking at the aim of this research, it's to investigate the relationship between resilience and associated factors, which I'll go into more detail about, among adolescents in an international school in the UAE. So we're looking at my objectives. There's 5 key objectives. So it's to assess the influence of socio-demographic factors on adolescent resilience using a demographic questionnaire, to evaluate the impact of mental health on adolescent resilience using the PMH Kids. I will go into more detail about all of the measures shortly. The third one is to determine the association with parent relationship on adolescent resilience. So this will look at parent attachment, but also parenting styles as well. And then to assess the influence of community factors and societal factors, cultural factors as well. And these 2 objectives will use 2 different parts of the MacArthur scale of subjective social status. So I'm not going to read through all the hypotheses with you, but this is just to give you a bit of an overview. So all the associated factors do have a possible null hypothesis and alternative hypothesis. I would kind of lean towards predicting that there is likely to be alternative hypothesis for most of the factors, because it seems that they would have an impact on resilience. The only one would be with mental health. It would be likely to have a more significantly negative relationship, because if things like depression and anxiety signs are lower, it's likely that the resilience would be higher. So then we're looking at the methods that I'll be using. So it's a quantitative cross-sectional design. There's a little picture in the corner of the school from a bird's eye view. So you can get an idea of the UAE, but also what the school looks like. And so as it's cross-sectional, I'll be using the Strobe guidelines for my reporting. So to give you a kind of overview or summary or idea of the UAE, so it is a very popular expatriate country. So a lot of expats move here because of job opportunities, and there's no tax payments, which is quite an appealing part of it as well. So because of this, there's a lot of international schools, and they do have a big mix of cultures. So it does make my school, the school where I'm at, an international school, a very interesting place to do this research, because of all the different backgrounds and cultures that will be part of it, alongside the local traditional Emirati culture, which also plays an impact as well. We're looking specifically at my population, so I'll include adolescents aged 12 to 18 years. So it will be most of the senior school students are in the sampling frame, enrolled at KCD, which is the school. They're able to complete online surveys themselves, and both adolescents and parents involved must speak or and read English. The only participants would be excluded is any students outside that age range. And then also, because I'm a school counselor, it would be any students that are on my caseload at the time of recruitment, just to prevent any ethical issues or it impacting the, the counseling relationship. And then finally, any adolescents that do not have parents willing to participate as well. So just to give you an idea of my sampling recruitment, so the way I'm using convenience sampling because I'm using a school where adolescents are based anyways, but also I work at the school, which also makes it more convenient as well. A notice to recruit participants, a notice will be sent to students and also a letter to parents within the sampling frame. So all the parents of all those students in that sampling frame will be notified, and this will provide relevant information, and then they'll be able to sign up. Due to my role in the school, it'll be very clear that it'll be anonymous, which will reduce the chance of bias and potential coercion. And then if you look at the little diagram on the left, so my sample frame is 400 students, there's 400 in total in that age range at the school. And from that sample, using a sample size calculation, I worked out that I would limit it to 140 student parent pairs, so 140 students and their parents. And it would be 50% boys, 50% girls. And when they sign up, there does need to be at least one parent needs to participate. So it doesn't need to involve both parents. Okay, so my study procedure, so starting from ethics approval, so I'd have to get the approval from Stellenbosch University Ethics Board where I'm registered. And then following that, it would be through my school principal and the head of senior school as well. And then Alder Education is the company that own our school. They own a number of schools in the UAE, so we'd need approval from them too. And then finally, the KHDA, which is the UAE Education Board. And then we'd move on to the next step of recruitment sampling, which I've already outlined for you. And then going on to data collection. So how it would work is all the surveys will be designed on RedCap. Parents, which is the online platform for surveys, and the parents would complete their survey first, and then if they then consent for their parent to participate, they insert the child's email address at the end, which then the child would then receive an email with the link for them to then complete their part of the survey. So it'll all be anonymous. The parents won't be able to see their child's responses and vice versa. Then once all that's collected, the data analysis would take place and paired responses. So the student and parent responses would get a participant number to make sure that it's anonymous. And then finally, the data is downloaded and imported to SBS for analysis, followed by then that going into the report. And then the final step is really important as well, which is a thank you. So all the participants will get a flyer with the summary of the findings, and they would also have their compensation as well. So we're looking at more detail into the measures. So firstly, starting with the independent variables. So each one has a measure to kind of assess this or collect the data. So, and these will all be put into the survey. So the sociodemographic factors would be looked at through the demographic questionnaire. So asking questions around age, ethnicity, income, gender. So in other parts of the world, you might have more options than male and female, but in the UAE, it's still very traditional and it's illegal. So it's only male and female is possible. So that's the only options that would be given. And then we'll move on to the students being asked about their questions about their mental health using the positive mental health scale for children and adolescents, which is a 9-item self-reporting measure. And then to measure the family, this is where the parents come in. The questions that they have will be from the Parenting Styles and Dimensions questionnaire, which is a 32-item self-report measure. And this has been used in Saudi Arabia, so not in the UAE, but Saudi Arabia is quite a similar context to UAE, and they found it to be valid in their study. And then going on to the community, so this will be included again in the students' survey. They will answer questions from part 2 of the immediate social, which is the immediate social environment part of the MacArthur scale of subjective social status, the youth version. And then finally, when looking at culture, there'll be the same questionnaire, but part 1, which was more around traditional socioeconomic status. Okay, and then the final measure is for the dependent variable, which is the resilience. And this will be using the adolescent resilience questionnaire, which takes into account elements of well-being, family, community, and society, which then also speaks to the associated factors as well as resilience. So all these measures have been validated in other countries, but not in the UAE. So because of this, I will have to do, in the data analysis section, I'll have to do a Kronbach alpha to check the validity of all the measures. Okay, and then I'll go on to the data analysis. So the data will be screened for missing values initially once it's all collected and then downloaded onto SPSS. And reverse scoring will also be inputted as well for all the relevant questions that require it. As mentioned about Kronbach alpha, so for the measures to assess their validity, and they would need a value of 0.70 or higher to be classed as valid. Then I'll assess for normal distribution using the Kolmogorov-Smirnov test, and then got on to doing descriptive statistics to be able to compare scores in certain groups along with the independent samples t-test as well. So compare resilience between genders for that, and then using the one-way ANOVA to compare resilience between age groups. At points where there's when I've tested for normal distribution, if there isn't normal distribution, then I will use the non-parametric tests instead of these tests. And the same goes for Pearson's correlation as well. And this is really the crux of the research, because this will help to answer the correlation between resilience and the variables. And then when doing the analysis, when looking at data safety, which is really important, these responses will all be kept secure, and there won't be any identifying information to any of the participants. Okay, so we're looking at my ethical considerations, so potential risks and discomforts. There may be times when participants might find some of the questions a bit unsettling or upsetting. And so at the beginning of the study, when they get the information, there will be very clear information about who they can go to for support. And they'll also be informed that they can skip questions that cause severe distress. Then when looking at, on the other hand, looking at potential benefits, so it can lead to adolescents reflecting on the different factors in their life, and so could actually end up maybe them making some changes and strengthening their resilience in that way. But it also could indirectly benefit both the students and the parents involved, because it could inform the part of this research is planned to be used to inform future initiatives at the school. So it would then benefit them. And then when looking at one of the key ethical considerations of informed consent assent process, so as these are minors, they're age 12 to 18, parent consent is really important, but students will also give their consent as well. When the information is provided to them at the beginning, there will be a checkbox for them to tick that they have understood everything. And if not, then I will have to address that, or they either won't be in the study, or I could reach out to them to find out to answer their questions. And then voluntariness is also really important. So no one will be forced into this, and they can opt out at any time. And then we're looking at privacy and confidentiality. So everything will be anonymous, all the responses, and everyone will be assigned a participant number rather than names.
Great.
And then,
thanks, Emily.
Yes.
Sorry, Emily, I think just one more sentence to wrap up, and then you've come to the end of your time.
Okay, thank you. Okay, now I'm almost yeah, I'll just quickly finish off here. So as I mentioned, reimbursement would be vouchers that they can use at the school, coffee shop, and canteen. And at the end of the study, I already mentioned it will be used to inform future initiatives at the school. And then just to end off, I'd just like to quickly thank a few people. So just like to thank my supervisor, Professor Bronwyn Coetzee, the CPMH team, so Professor Claire, Professor Kath, and everyone on the team, just for all your ongoing guidance and support. My fellow MPhil colleagues who have we've been working together, and then just my family, my husband and parents and siblings, yeah, just for all your support. Thank you.
Great, thank you so much, Emily. That was beautifully presented. It's a lovely study. I'm sorry I had to chip in there at the end. We would all love to keep listening to the study for at least another 10 minutes. So now, sorry, Kevin's just sharing. Okay, so I just want to, your reviewer, Associate Professor Tara Carney, couldn't be here today, so I'm going to read her comments. All right.
Okay.
Okay.
Yeah.
And I'm going to go through it and then you'll have a chance to respond. So Tara was very happy to review your protocol and she said it's very clearly written and the topic is interesting and important as we pivot away from only focusing on common mental health conditions and moving more towards well-being. She also acknowledges, and I think you and your supervisor have been chatting about this, resilience is a complex phenomenon. And she's given you some tips and some other readings, which you may or may not have included already. But she would say just from the start, just define what you mean by adolescence, because there are people who use different age ranges and definitions. And she also suggests looking at a few resilience references, which I will pass on to you. One thing she was asking was, are you going to ask about any key adversities or challenges faced by the population? Will you include trauma measures? Or are you sort of only focusing on the positive psychology side? She would ask, that was one of the things she was asking. Okay. She did have a question about the measure. She suggested the child and youth resilience measure, which you've probably come across, which has been widely used. So she suggested maybe looking at that. She also suggested the literature on resilience, looking at promotive, protective factors and processes of resilience. And she's given you some references there in case this is something you haven't come across. And then she's got a question about the parenting measure. Are you interested in the type of parenting or also the quality of relationship between parent and child? And she speaks about the Alabama parenting questionnaire, the short version. Okay, so that was one of the thing, and one of the last ones she spoke about was, have you considered using a regression analysis with resilience? Because resilience would be then your dependent variable, and she just said you put the data together in such a way that it lends itself to this type of analysis. She wondered if you'd thought about that. And then the last comment she had was about, in terms of privacy and confidentiality, where will the kids be when they answer the survey? Will the school staff be around? And also, if there are any incentives, vouchers or snacks. But generally, Tara says this is a very good study and she enjoyed going through it. And she said, good luck with the next steps of your MPhil. So Emily, you'll have a chance to respond. I've gone through a few questions, so I can go back to some of them if they weren't clear.
Okay. No, thank you very much. I think that's all really helpful feedback. It's quite, yeah, I think to respond, it's a lot of that I would like to take on board. And I also appreciate the references as well. I think that's going to be, yeah, really helpful just with taking this research forward. Yeah, I think in terms of the challenges and looking at trauma measures, I would think that would come up a little bit in some of the surveys, and some of the questions that are asked, but I think that's also a good thing to look at is maybe possibly to figure out maybe how to bring that in a bit more, because obviously trauma does have a big impact on resilience as well. And as I think a lot of people might think, the UAE kids don't really go through many challenges, but actually they come from a lot of different contexts. So a lot of them have been through previous trauma and also go through things here that can be traumatic as well. So I think that is a crucial one that I would like to look more into going forward on how to maybe bring more of a focus on that. With the child and youth resilience measure, I think that might be a good idea because The measure that, and looking at more of the measures, when I put them all out together, it does look like the one that I do have is quite long. So perhaps it might be good to find a bit of a shorter measure, because already they've got quite a lot of surveys to complete. So I will definitely look into more into the child and youth resilience measure. And then the question about the type or quality of parenting. So how this research developed is, initially I was just going to focus on, but my initial focus was parenting styles and resilience, and then I've added, because it's correlation, obviously added more factors as I've developed the research project. So I would say that I would like to include a bit of both, and that's the reason that I brought in the parenting questionnaire that I have, because it touches on both parenting styles and parent attachment. So my idea was to look at both, because I think both have both the quality of the relationship, but also the parenting style. I think both play a very key role in impacting young people. But I will look at the Alabama parenting questionnaire as well. And then finally, just the one about the regression analysis. It's something I've been talking about with my supervisor this week, actually. So that is something I'm considering taking forward. And privacy and confidentiality, there won't be staff there. So students will get the link and they can do it in their own time on their devices. Yeah.
Perfect. Thanks so much, Emily, for your clear responses. I think we run out of question and answer time, so we are going to go on to the next presenter, but well done. Congrats. It's good to listen to it.
Thank you. Thank you, everyone.
So our next presenter is Ms Lesley-Ann Erasmus. She's a long-time friend of CPMH, so it's great to have her presenting here.
Morning, everyone. So I'll be talking about my MPhil. It's about polysubstance use during pregnancy, the initiation, continuation, and lived experience of women in the Western Cape. As you all know, maternal alcohol use in South Africa is obviously still a public health concern, and we have high prevalence rate, national prevalence rate of 3.7%. And within the Western Cape, it's obviously higher, ranging between 20 and 37% among pregnant women. And fetal alcohol spectrum disorders are also very prevalent within the Western Cape, with high numbers. In South Africa, the polysubstance use is also increasing. Very often, women who are pregnant and using alcohol, they're also using other substances, such as cannabis, tobacco. So I'll be embedding my qualitative study within the Marissa Plus study, and I just want to give a brief overview of what that study is about. So the Marissa Plus study is, it aims to adapt and test a behavioral intervention to prevent FSD and adverse infant outcomes. It has had 3 stages, and they are in the planning phase of a RCT. And the RCT is planned to start soon, hopefully. But it aims to look at the effectiveness of the adapted intervention on polysubstance abstinence, and the impact it has on birth outcomes. And in addition to that, they will be doing a cost-effective analysis. Just the image on your right is the project study design. So all women will be screened, consent and baseline, and randomized into 2 groups. The intervention would be a contingency management and health promoting text-based support. And the treatment as usual group would be receiving referrals for extra care, but they will be receiving their normal primary health care. Women will be followed up at 33 weeks gestation, 6 weeks postpartum, and 14 weeks postpartum. And between those appointments, they will be receiving monthly monitoring. But the entire population will be receiving the monthly monitoring visit. Now, the monthly monitoring visit for the intervention group will be linked to financial incentives. So within like the rationale for my study is the fact that there's been predominantly quantitative and epidemiological methods used to study polysubstance use in South Africa and globally. So the need to do a more in-depth and qualitative study is needed. There hasn't been a lot of work done with women to determine or get a better understanding of their lived experiences and the dynamics between the contextual stresses that shape their initiation and the continued use of polysubstance use during pregnancy. This qualitative study is also to inform the development of effective and targeted culturally sensitive interventions within the primary healthcare sector. My research question is what are the lived experiences contributing to the initiation and continuation of polysubstance use among pregnant women from low socioeconomic backgrounds in the Western Cape, South Africa? As I've mentioned already, my study seeks to explore the lived experiences of women and individuals' understanding of the stresses which possibly influence into shared substance use. So I've got 4 objectives to explore the individual's lived experience of polysubstance use before conceiving and while pregnant, to explore the socio-cultural and environmental factors contributing to polysubstance use among pregnant women, to explore pregnant women's understanding of the stresses influencing the use, and identify and explore the contextual stresses that act as barriers for the barriers to cessation or reduction of the substance use. I'll be using a phenomenological approach and doing semi-structured one-on-one in-depth interviews with pregnant individuals. This method has been found to be more appropriate because it allows us to get a more in-depth perspective of where the phenomenon, like when did women start using substance or the multi-substances that they are using, and the other factors that might have contributed to that. As I mentioned, it's embedded in the Marissa Plus study. The Marissa Plus study has been, all the phases up to this point has been conducted within urban healthcare settings. What that means is it's been conducted in primary healthcare facilities within the Cape Town metropole. And characteristics of the Marissa population. So there's obviously a eligibility criteria: 18 years and older, women need to be pregnant, test positive for alcohol, nicotine, or cannabis on screening, be HIV negative. They don't do the HIV negative testing, but that will be based on the medical records. Women need to have their own cell phone and not plan to relocate within their pregnancy, and also 3 months postpartum. My expected sample size, looking at 20 to 30 women to interview. I'll be using purposive sampling from the Marissa Plus cohort, and to give me a range of more representativity, I will be looking at dividing the sample into 2 groups, one under 30 years old and from 31 years and up. And also women needed to have agreed to, within the consent form for the plus study, they would have had to be agreed to be contacted for further studies or further research. So the study procedure, I'll be doing all the data collection myself. Obviously, permission would be asked from women to audio record the in-depth interviews. They will either be in Afrikaans and English, and the only reason for that is because I only speak Afrikaans and English. The transcripts will be transcribed verbatim, and then if it's Afrikaans interview, it will be translated. And then I will also be taking notes during the interviews of my observations, and also reflect on my own ideas and perceptions, especially how, because I would have had no contact with the population prior to doing the interviews. I'm the project coordinator of the study. So I would, I obviously have to look at how my engagement with the individual could have impact the content of the interviews. I'm planning for interviews to be around 40 to 60 minutes. And then for data analysis, we're looking at Braun and Clark's reflexive thematic analysis to be done, and that has a six-step approach, which is familiarization, coding, searching for themes, reviewing themes, and writing up the results. And just a brief, so I would be doing all the familiarization initially, and to create a code book, and from there, I'll be engaging with my supervisor as a second researcher to see if we can determine Cohen's kappa or score, and also to just clear about the coding, the code book, and how the definition of code, etc. I'll be using MPhil as the software to analyze my data, and I've taken in consideration some methods to increase the trustworthiness of the research. One of them being, obviously, as I said, taking notes and reflexive journaling, as well as speaking with my supervisor, and also planning to do member checking, which means I will be going back to the participants, asking them to look through the transcripts prior to analyzing the data to make sure that they that what is being said in the interview is actually that they agree with what has been said. Okay. Ethical considerations. So there's just two risks that I considered, and that's the possible disclosure of confidential information, more in the sense of someone seeing them coming to the interview at the health facility and knowing that they're taking part in the research, and then exposure to mental discomfort associated with the sensitive topics. The potential benefits is that they will be sharing their experiences within a safe environment, and that might allow them to express themselves. The data will give us a better understanding of the history of polysubstance use among pregnant women and the needs of that vulnerable group. I won't go through too much detail in terms of the informed consent process, since we all know how that works, but emphasis will be put on that if research is voluntary and they can withdraw at any time without any consequences. I'll be seeking ethical approval from UCT, HREC, and MRC, since the embedded study is through the MRC, and the participants will be receiving reimbursements of 150 compensating for their time. Limitations would be that my recruitment strategy is heavily impacted by the recruitment strategy or the recruitment pace of the larger RCT. Due to limited resources like budget, and I'm the only data collector, that can be a limitation, and that the sub-study is not representative of the views and experiences of individuals from other geographical regions or higher socioeconomic background. Thank you.
Okay, I think Lesley-Ann, you can sit there. This is I'm also going to be presenting your reviewers' comments. Okay, thank you for a lovely presentation. So a really good one, and yeah, beautifully presented. Thanks. And the reviewer, who is Prof. Rizwana Romani, she's very well written protocol. And she has some suggestions for the expanded protocol, but she understands this with a brief version. She said the relationship between the larger study and the sub-study was clear, which is a key in your work. And the methods are clear and aligned with the objectives. She, about your sampling, would you like to recommend convenient sampling? and that she suggests that a randomized number generator is not needed. Study. She likes the way you pay careful attention to ethical considerations and your methods of data collection are strong. There's one, I think you've had this question before, there's one comprehensive question about exactly how it will work, how each person will have consented to be contacted and what information will be shared when and how you will do that. And that is generally it. She's given you a few small comments in your protocol. So would you like to respond?
Yeah, no, I take in consideration the randomizer. So a randomizer, not so, and that it actually is convenient sampling. Change.
Just that.
Which would be women would have had to agree to contact other research and to be contacted the bring it in already, and that allows me to I mean, I will also be looking at marketing material so that we people and just to explain, not to have a blanket of just giving permission contacted, but just to have an idea that this is substudy.
Right. And you are part of the original study team.
Yeah.
That asked that. Yeah, consent. Sure. We can open to the floor for any questions or comments.
Hi, Perinatal Mental Health Project. That's the growth release. I think I forgot. My concern in terms of the plan, and apologies if I missed it, but when in the process of the actual intervention, you doing that getting my contact, they actually influence that's actually my that experience. They end up having discussion of confidential, but not your focus. And how are you going to be able to ensure how you experience?
So what I just want to mention now is that you saw the time points of the monthly. So my initial idea was to try and get them between baseline and the first monthly, between that period. And if that is not possible, to try and get them that period between baseline and the 33-week gestation follow-up, because they still be pregnant and still they might not have as much exposure to the intervention, but because they will be enrolled within the second trimester. But I mean, a woman that's enrolled at 13 weeks to 28 weeks, a woman that's enrolled on 26 weeks. I mean, who don't have exposed much before the 3-week gestation. Can I answer your question? Yeah, the long exposure. Yeah, the longer exposure. It's something that I will special look how we can.
I always love your strategic thinking and how that's it. When it comes to phenomenology, it's really about individual experience. I often find that 35 minutes to an hour interview doesn't always allow. I'm wondering if you could have thought about that, given your whether there's a potential innovative approaches that could work, maybe a photo voice, or maybe some collective journal that they do that share with you, having having a bit more contact, really dig into that individual experience. Something you thought about.
Thank you. Those ideas. I can definitely think about how I can incorporate that.
Questions or comments? Just checking the chat. If someone asks in the chat, why is the sample size so small? Last question.
Just because of the limited. And also it might increase with determining saturation with the regional pump.
Yes, that's right.
Saturation.
Right. Thanks, Cynthia. What about you? Yeah. So next up is Ms Tyla Prinsloo, who's staff, friend, and student. So she's gonna go ahead, and then her reviewer will give comments on Zoom. Okay. Obviously, we tried to angle it so that the speaker is talking to both audiences.
Here we go. Good morning, everybody. My name is Tyla Prinsloo, and I am a registered counsellor with the Health Professions Council of South Africa, and I am based at the Perinatal Mental Health Project within the CPMH. I'm really excited to discuss my qualitative study with you. I'm a graduate of the PG DIP, so I've been thinking about this for a very long time. Just to situate our thinking in terms of where we are, so systematic reviews indicate that common perinatal mental health conditions, particularly anxiety and depression during pregnancy and postnatally, impact 1 in 4 women in low and middle income countries. And there are multiple risk factors that are associated with this, including social determinants. And what we are particularly concerned about is that service delivery is prioritized at tertiary level care and for more serious mental health conditions, which means that there is quite a significant treatment gap for women experiencing these common perinatal mental health conditions not receiving treatment. So in an effort to reduce this treatment gap, the World Health Organization has promoted a task sharing initiative where mental health interventions are delivered by non-specialist practitioners in an effort to expand reach and sort of reduce this gap. So the Perinatal Mental Health Project is one such example of an integrated maternal support service at primary healthcare level. It is multi-component collaborative stepped care approach that utilizes a prevention intervention model. So the description on the screen, women who are attending the antenatal facility are exposed to a waiting room discussion that endeavors to promote mental health, prevent stigma, and prepare women for this kind of service engagement. Nurses and midwives take women through a 3-item brief screening questionnaire around anxiety, depression, and suicidal ideation. And thereafter, they are referred to the registered counsellors at the PMHP, where we engage with women and we assess and triage them based on a 14-item risk factor assessment. And they triaged into 3 levels of care. For the purposes of my study, I'll be focusing on the low and moderate need client group and the high level client group. Service is available for the duration of the pregnancy up until a year after the baby is born. So we're trying to capture that perinatal period as best as we can. And there's not necessarily a limit to how many sessions women can attend. So it's quite an unlimited amount during pregnancy into that postnatal period. So in terms of why I'm wanting to do this research, on the screen you will see previous research conducted on the PMHP. These papers are incredibly useful. However, they have narrowed focus points and they do not necessarily reflect the current service time, particularly that waiting room discussion and the engage assess triage section. And this needs to be explored in a little bit more detail to be able to understand clients' use of that service pathway and what that engagement looks like. So we can understand deeper factors that impact that engagement and the use of the service as well. So qualitative research will allow us to really look at service design and optimization based on clients' articulated needs so that we're implementing something that works for our population. Our aim is to explore the experiences of women who have utilized the maternal support service. The objectives to understand the experience and perceived benefits or outcomes that women have with the services, how they use it, how they don't use it, to understand barriers and facilitators to access and engagement, whether this is internal or external, and then to also elicit recommendations for improvement of the service. So the study setting, the Perinatal Mental Health Project is based at a primary healthcare facility in Hanover Park in Cape Town. So it's integrated into the Midwives Obstetric Unit, so in the primary healthcare setting. In Hanover Park, which is an urban area in Cape Town, which is established as a result of the Group Areas Act of 1950. So I've noted this particularly because the area is characterized by many socio-political inequalities and social determinants of mental health impact upon clients living in this area. So our study design is descriptive, exploratory, qualitative design. In terms of sampling and recruitment, because I am part of the service delivery team and in a bit of a dual role with research, I would need to, for the sake of bias, not be involved in data collection. So we would use a purposive sampling strategy to be able to sample clients who have used the service in various ways. We've sort of decided that minimum engagement would be about one to two sessions. An average engagement is about 3 to 4 sessions, and anything greater than 5 is quite a lot of engagement. And we're wanting to sample across that use, and also with different kinds of presenting problems, different kinds of client demographics as well. We will sample until data saturation is reached, but for the purposes of an estimation, we'll go between 12 to 20 participants. There is a REDCap database that's used as a repository for the counseling service, which could be mined to identify potential participants to access. And contact will be made to ascertain initial interest, and then a research assistant will sort of go through the recruitment process of contacting the participant and arranging the data collection strategy. All right, so data collection will be open-ended, semi-structured individual interviews, roughly 45 to 60 minutes, at a location that's convenient for the participants. What we'll also want to do is ensure that the data collector or the interviewer is not part of the service delivery team, and ensure that they are trained in qualitative data collection methods and interviewing in particular. And then the interview guide would sort of revolve around those research objectives, service experience, benefits or outcomes, facilitators and barriers, and then the recommendations as well. In terms of analyzing the data, we would be using a thematic analysis approach. I'm looking at mitigating bias as much as possible. So social desirability bias with respondents. I'm not involved in the data collection. In terms of analysis, I will not be a single coder, there'll be multiple coders, so I can be held accountable and reflexive as possible. And I'm going to leave this open to the audience a little bit. I initially thought of inductive coding for the coding strategy, but I imagine that deductive might also be a useful strategy to determine what the clients are experiencing and whether that matches the existing literature on service use and service engagement. So I initially indicated inductive coding because I've been very mindful of bias, but I might then marry the two in terms of, or choose between the two, but look at the value of insider research connected to this kind of study and the insights that could be generated in that way. And then the in vivo data analysis software will be used to sort of house the thematic analysis as well. In terms of ethical considerations, I've looked at embedding reflexivity throughout the research process to establish trustworthiness. There's going to be multiple coders. I'm going to write up the study in line with the codec guidelines. I'm looking at the ethical considerations below. I know that the study sample and population is particularly vulnerable, and I would look at including a distressed participant through standard operating procedure, that in the event that in the interview there is distress, that the participant will be contained and referred to in-house support if needed, or external support services that is required. In terms of informed consent, ensuring that our participants are clear and prepared for what they're doing, they know what they're getting themselves involved in and why they're participating in that kind of research, particularly about experiences. In terms of privacy and confidentiality, a lot of the data will be de-identified once it's recorded and transcribed, so that nothing is identifying participants to themselves. If any quotes are used in the write-up, it won't be quotes that's only identifiable to particular participants. And data management will be managed according to the relevant UCT guidelines. And with regards to member checking and trustworthiness, just to go back to that one, I've thought a lot about it. Our participants, especially people who engage more minimally with the service, are relatively hard to reach. So I imagine that trying to access participants after data collection might be a little bit tricky. So what I've looked into is embedding the member checking within the interview process as well. So as the person is in the interview, as the participant is discussing their answers, have the interviewer probe with paraphrasing to ensure that there's clarity in meaning and clarity in comprehension, so that it's a degree of member checking while the interview is happening in the event that we cannot access participants again. So just to get that as well. Just to wrap up, I'd like to acknowledge the Perinatal Mental Health Project, the women that we serve. I would like this project to represent their needs and their experiences at the forefront. The CPMH, Kevin said I live here, so I think I do. And in order for this research to have happened, I'm quite grateful for the Yamari Fellowship to be housed in this kind of Africa-focused research consortium. Is quite exciting. Yeah, looking forward to it.
Fantastic presentation. You've already got a few comments in the chat, one being a very impressive presentation.
Oh, yes, thank you.
And now we're going to have Carolyn Rusher online. She's a colleague and a PhD student.
Can you hear me? Yeah.
Thanks, Carolyn.
Okay. Thanks, Tyla. It's been a privilege to read your proposal and to comment on it. I love your enthusiasm for your subject matter, and it was a very well thought out proposal. I like the way you linked your rationale to your study design. I have made quite a lot of comments on the document, which I'm sure you'll get. So I'll just highlight a few things. I think up front, I just wanted to see a bit more about some of the other work that's been done. I know you focused on some of the limitations of the research that has already been done in the space of assessing the project, but to maybe expand a little bit more on that so we can understand a little bit about the background of what has or hasn't already been done. And then there were just little things around just particularly just how you worded your aims and objectives. I know you said to understand, but you're like doing an exploratory descriptive study. So, it's quite difficult because we can't intuitively understand somebody's experience, but maybe you're describing or to describe or explore the experiences of the services. And then just to some of the comments I made, I think you did actually address in your presentation that weren't actually in your documentation. So I've just made a note of that to make a link up. But I think maybe to be more explicit in terms of your inclusion and exclusion criteria. So when you say adult women who have used the services in the last 12 months, to maybe define an age range. Are you looking at how many times they've used, is there a specific, are you looking at how many times they've used the service? And that also then comes back to just another comment about maybe collecting some socio-demographic information related to have they used the service, how many times did they attend the counselling, have they used the service in a previous pregnancy or in the current pregnancy? And then I see in your presentation, you did actually define the period, the pregnant and perinatal period, because that isn't obvious within the documentation, how long that you're looking at defining that period. Just trying to see, and then just to be a bit careful when you're looking at your study procedure and your informed consent processes, just to be more, state more how you're going to obtain informed consent. You know, important to look at those things, the fact that the participant needs to explain back to you what they understand about the study and about the voluntariness that they can also pull out at any time, and the right to withdraw is kind of missing from those processes. And again, just to think through, maybe draw a little flow diagram in terms of how, because you said at a specified location. So I'm just wondering why you wouldn't get them back to the unit to do the interviews. Are you going to then travel to where they stay? And you need to think a little bit around some of the logistics and practicalities of this. These are all just really small things. And I think the main thing that you're not really going to like me for was what I was going to suggest, that I think some of this lends itself to maybe doing some quantitative work. I know you were kind of like steering away from the word quantitative, but kind of when I was reading it, I've given you some references as well to just look around things of around implementation science, especially when you're using things like you trying to look at things like the trying to make suggestions about the appropriateness, sustainability of the service, acceptability, etc. And I've also given you some references really to look at from that quantitative, if you want to look at some sort of user satisfaction, because I just felt that the way you're talking, because you're looking at the acceptability and the satisfaction with the service, to look maybe if you do add a quantitative component, looking at patient satisfaction, and that there's some references I've given you in the document to have a look at. I think that's the main things that I just thought I'd highlight, or you could look at for now. But obviously I put a lot more into the documents for you.
Okay, cool. Okay. Thank you, Carolyn. Can I respond? I know that I probably gave an impression that quantitative is not my friend. I will reintroduce myself to quantitative and make friends with quant. I do think that there is value in having it be mixed methods-ish. So I would want to discuss it in supervision and see how accessible that is to this kind of project in terms of time and logistics, and if it's going to support the research objectives, then I would want to be able to do something like that. Yes, given the minor logistical elements that you've mentioned earlier on, I would, in the bigger protocol, really outline very definitively what's happening in terms of informed consent, particularly with parole. So one thing would be that the participant data is labeled, and if it is at any point that they're wanting to withdraw, that they can be sort of reconnected to their data with that label. Yeah, and there were a couple of other things, but I'm quite excited to see your comments in the document and strengthening the project based on some of the. So thank you for that.
It's a pleasure, Tyla.
Great. Thanks, Carolyn, and thanks, Tyler. Nicely answered. I think we've probably got time for questions. I should say we've got time for questions, or we're going to ask a question.
We've got 2 minutes for questions.
2 minutes. Any questions for Tyler?
Yeah.
One thing, I mean, just to reinforce the quantitative idea, I think it would be a really nice combination with your in-depth qualitative exploration to collect some routine quantitative data, over say a 4 to 5 month period. It doesn't have to be complex and it doesn't have to be logistically difficult because everything is set up. I mean, project in there. You could look at either a brief satisfaction survey, and perhaps a brief mental health assessment, maybe the one that you use anyway. Then just nest your qualitative study within that. It will give you a really nice overview of the project. Thanks. It's a great project.
Thanks, Ben. I'm going to ask you a question.
Oh,
Sorry. One thing you spoke about insider, outsider. When you train your data collector, you know the service inside out. So if you were doing the interview, there would be some benefit.
Yeah.
Can you just talk about the pros and cons and how you would address it with your data collector, training them? How much would they know about the service?
I'm in two minds about that. So what I would potentially do, because I was trying to think about how to train the interview, how you would train an interviewer to do something like this that might not be service focused, I would maybe do mock interviews and see how the interviewer is able to maybe contain participants in various ways. I might maybe even offer that if it does the research, spend some time at the site, but to get a sense of how people move through the service, what the space feels like, what it's like really, and also sort of encourage that kind of probing discussion in the I think the insider research might come through quite strongly in that analytical point of view. Definitely, I would love to be involved in the interviews. I might just want to peek through the window, but I'll try and sort of prepare whoever's doing it if possible with different strategies. Yeah.
Right on.
Thank you.
Thanks so much, Tyler. Well done. Okay, now we are moving on to Dr. Ms Lesley-Ann. Starting off, and there's a very encouraging audience online and in person. We're looking forward to hearing your presentation.
Good morning, everyone. Enthusiastic response. So I see that Tyla and Lesley-Ann didn't finish the entire 12 minutes, so I'm sure I can harvest some of those. Let's be honest. All right, I'll try to project. So I'm Ms Tyla. I've broken down my research topic into manageable and digestible bits. So I'm going to be looking on exploring healthcare managers and primary health service users' perceptions of mental health service delivery in the district, so in the facilities that they access help from. And I'm also going to be exploring their recommendations for improved care for people who are living with common mental conditions. So why is this, and why am I doing this study? What do we know currently? We know this is high prevalence of mental health conditions in high income countries, including low and medium income countries, and those have contributed to the burden, also the growing burden of disease. We know this, their mental health care results constraints. For example, if you're looking at the South African context, more resources are used in your tertiary institutions or tertiary startups, whereas less budgeting or less funding is allocated to your district and primary health care setting. And what has been done then to address this issue? So there have been some recommendations in terms of what models or health innovation can be put in place in order to try and bridge this gap. For an example, the integration of mental health care into general health care in the primary setting. So where is the gap that we've identified? If you're looking at research largely in the area of mental health care integration, we know this focus has been on the perceptions and experiences of healthcare service managers and providers. And what that has left is a void in terms of the views and experiences and perceptions of healthcare users. So we've seen this top-down kind of approach where we come with, expert crafted interventions and imposing them in those areas. And we know that despite the strong evidence, despite the strong evidence of the feasibility and accessibility of task shifting, the implementation has been a lot of challenges. There is not so much widespread implementation of task shifting. This could be due to a number of factors such as resistance from healthcare practitioners, funding, supervision issues as well. So as much as there is strong evidence for this model, the implementation is a bit of a challenge. So how am I planning to bridge this gap? So number one is by exploring local knowledge on the current mental health care models. So for example, what exists at the ground level, a lot of people using in terms of bridging the gap, uncovering locally relevant solutions to the feasibility and sustainability of potential health innovations. So I think the most important thing we're looking at, how sustainable are those models? And if we were to introduce a different healthcare innovation, how sustainable and how usable it's going to be for the service user? And how can those services be made more culturally and contextually relevant? So I've already spoken about my aim, so I'm just going to focus on that. I'm not going to read the objectives as well. I'm just going to do a summary. So if we're looking at the first objective, we're looking at what kind of services exist at the ground level. What are some of the gaps that are identified by both healthcare providers and service users? What models are available, and are they formal, are they informal? If we're looking at the second objective, we're looking at what recommendations can those individuals make? What do they think might work for them? Taking into account your social, your contextual, and your cultural factors. And the third objective is, if we as researchers, as advocates, if we were to introduce other models to cover the gap or to complement the already existing models, how can we do that in a more acceptable and sustainable manner? Study methods, I'm going to use a mixed study approach against my own standard campus. Anyway, so the qualitative aspects will use an exploratory descriptive approach, while the quantitative aspects will include the descriptive data analysis from the healthcare, from health information system for both of the studies. I'm going to focus on two study sites. The first one is the Mossford Hospital, which is a 246-bed hospital, and provides services to about 110,000 people. I'm going to be looking at your healthcare managers. And the second study site, I'm going to be looking at Otobotini, which is a community healthcare center located about 54 kilometers away from Mossford Hospital, and provides services to a catchment area of about 96,000 people. So at the CHC, I'm going to be looking at both the healthcare managers and service users. The kind of healthcare managers I'm going to be looking at will include your medical and clinical managers, your allied managers, your nursing managers, heads of departments, social work, occupational health, maybe some supervisors from HIV and AIDS services. Inclusion and exclusion criteria with regard to the managers, they must be in the employ of the department. They must have been working in that particular facility for at least over a year. Exclusion criteria with the managers who have not been involved in mental health care delivery in the district for about a year or more, because those individuals might not be able to provide the in-depth information that is relevant for the study. Including criteria for healthcare users. They must be receiving health services from the CHC. They must have some basic knowledge of common mental conditions, and they must be at least 18 years or older. Service users who are unable to provide consent, for example, maybe as a result of an intellectual disability or severe mental illness, will not be included. The process of rolling out the study, ethics application from UCT, I think that's a must. I have to do that. And after that, obtaining ethics approval from the Provincial Health Research Ethics Committee of KwaZulu-Natal Department of Health. And then definitely after getting that approval, communicating with the gatekeepers from the hospital and the CHC to gain entrance to the sites. I will use a research assistant to assist in the recruitment of healthcare users. In terms of the recruitment for healthcare managers, I will present the study in different ways and I'll see which one is more feasible at that stage. Number one could be presenting at the appropriate staff meeting or presenting at a meeting that I will have scheduled with the healthcare manager, or sending them a detailed letter or email detailing the study. I will make follow up with the healthcare managers via email or telephone call, but they will also be provided details of the researcher in case they want to indicate their participation. With regard to recruitment for the healthcare users, I will work with the research assistant. I will use convenience sampling in the recruitment. I will use two screening tools to include people in the sample. For example, participants will be asked if they understand common terms that are used to refer to common mental conditions, either clinical terms or terms that are used in the everyday language. And if the participants have heard of the terms, a few items from two mental health literacy tools will be used: the depression literary questionnaire or the anxiety literacy questionnaire, the DLIT and AIDS. If individuals are able to answer positively or demonstrate some knowledge of information about either the depression and anxiety, if they're able to answer correctly at least two items, they will be enrolled in the study. Healthcare users who have no knowledge of common mental conditions will not be included in the study, because this is focused on the services that are going to be used, important for people who are living with common mental conditions. Data collection, so I will use a semi-structured interview schedule and case vignettes. So for example, the interview schedule will be adapted for both the individual interviews. I will do the individual interviews with healthcare managers, which are going to be about 50 to 60 minutes, and then focus group with healthcare managers. Focus groups with healthcare service users. The interview will be mirroring the aim of the study, so it might look at topics such as participants' perceptions and experiences of current mental health services, their perceived gaps of mental health services delivery, their perceptions of the current models and approaches that are used currently to deliver mental health services. With regard to the case vignettes, they will be depicting participants in care delivery using different approaches such as task shifting. So the vignettes will help with the focus group participants in order to gauge their understanding of common mental disorders and to help them think more broadly about what kind of intervention can be implemented to bridge the gap. So just to go back, as the interviewer, I will be involved in collecting data with the healthcare providers, and the research assistant will be involved in collecting data with the healthcare services. Data collection from the health information system, I'll be looking at your post establishments, what kind of posts are available, what kind of posts are filled, number of beds for healthcare service users, admissions for anxiety, depression, dispensed chronic medication for mental health care service users, and referrals that are made to social work departments, for example, parasuicide and counseling, basic counseling. I will use SPSS for the descriptive analysis, use of thematic analysis in the analysis of qualitative data, and I will use NVivo for the qualitative data. There will be 2 or more coders, including myself and the supervisors, and we will all code independently, then come back together to see if there is inter-coder reliability. The trustworthiness, looking at codability, peer debriefing, for example, with the supervisors, triangulation, member checking, being explicit about the limitations of the study, being explicit about the non-generalizability of the results of the study, using inclusion and exclusion criteria, and use of standard data collection measures to ensure fairness. Informed consent, I will be looking at, when I discuss informed consent with the participants, the purpose of the study, the importance of the study, the voluntary participation, and the fact that participants can withdraw from the study at any point without experiencing any negative consequences. We're looking at risk and benefits of the study, The material is going to be translated into isiZulu so that people really understand what is being asked of them. Safe storage of the data. So all the material is going to be stored in a lockable cabinet that I only have access to. And then audio recordings will be stored in a password protected computer where only the researcher has access to. Potential benefits of the study is going to be looking at, what are the psychological discomforts and how to manage that. What are the economical risks? How to manage that as well. And the benefits might increase awareness of mental health services in the district, provide a cathartic space for the participants, and maybe the long-term kind of benefits would be if there's an implementation of a model that will benefit the service. Thank you, and thank you to my lovely supervisors and to Amari Fellowship for the Mula. And
Thank you so much. So that was a really lovely presentation, and you obviously covered quite a lot of ground in that. So, so well done for getting through all of that. Now we have your review online. Our colleague, Prof. Bronwyn Kutsia. Bronwyn,
Hi.
you can unmute. Hi, thanks for joining us. Okay, go ahead.
Thanks very much, Claire, and thank you, Nkaniso, for a really nicely put together proposal. I can see you've definitely done a lot of work on it already, and you are so close, I think, to being able to actually, finish it off and move on to the next round. So well done to getting to this point. And thank you, Claire and colleagues, for the flexibility to give my feedback online this morning. I appreciate it. So to start with, the rationale is very clear and well argued, and the study is clearly important. So you make it clear that despite an increase in mental health conditions globally and in South Africa, there remains a gap in service delivery, particularly that the distribution of resources at tertiary and primary care levels are unequal, so to speak. And this means that at primary care levels especially, there are few human and financial resources to support the mental health of service users. So that's good, and that's very clear. Then you speak about task sharing and task shifting as an important way in which these gaps in service delivery have been addressed. And I think here in the proposal, when you develop the full proposal, you might want to highlight what are some of the issues with task sharing or task shifting? What are some of the issues with some of the existing models that are in place to bridge gaps in service delivery from the literature? So what works and what doesn't work, and where innovation is needed, just to sort of also position your study, which asks the questions around what can be done to better bridge this gap. And then you also argue that what we understand about service delivery is often from healthcare providers' perspectives and less from service users. So it's great that you're adding the perspectives of both, and really you're looking at a mix of stakeholders in the study, which is very interesting. Then in your objectives, I think the only thing that I would like to add here is that it might be helpful when you structure your proposal to do so with your stated objectives, so that it's clear who are the participants involved in each objective, but also importantly that you have an objective that speaks to the descriptive data that you're collecting in the study. So when I read your objectives, it's very clear. In fact, when you read the objectives, it reads very much more like an only qualitative study, where it's quite clear that you've got actually a mixed methods approach here and a parallel mixed methods approach, I think, because I think the descriptive data that you're collecting on the numbers of healthcare providers and so on, you're probably going to collect at the same time as these qualitative data. So the parallel mixed method design might be good to kind of anchor the research design more broadly. And then as you structure the objectives, make sure that there's an objective that speaks then to the collection of those descriptive data. And then that will help you also think about, in your data analysis section, when you talk about triangulation, what does that mean here? So the perspectives that you obtain from your the healthcare providers or the managers in particular, the service users, and these descriptive data how are you going to bring this together? What does triangulation then really mean in your study? So objective 1 and 2 are quite clear. These are healthcare managers and primary healthcare service users' perceptions. You then ask for their recommendations for health innovations. And then the third objective, which is to explore healthcare managers and community members' perspectives. I wasn't clear who the community members were here. Are these different to the healthcare service users that you are referring to already? And might you just want to change the language? Or is it that you're interested in a different group of participants here that aren't the healthcare service users? And maybe just clarifying that would be helpful. Then the study will be conducted at two sites, and maybe you just want to say how, if at all, you are linked, you personally are linked to these facilities. That might be nice. Then it's clear, you know, that the healthcare managers are participant group 1, and that's fine. But maybe we can talk a little bit about your service users that you're including in the study. So you're saying that you'll be sort of approaching service users in the waiting areas of these 2 facilities, and that you would use either the D-lit or the A-lit. I didn't see the A-lit in the proposal, so it's nice that both will be included. To screen participants' knowledge of mental health conditions, and only individuals with basic knowledge of these conditions will be included in the sample. So I wondered why sort of anybody with knowledge of depression and anxiety is eligible to be the service user of focus for this particular study, and why it's not someone who may be experiencing symptoms of depression or anxiety, or have anxiety and depression, who may then be knowledgeable about the services that they've been receiving in these facilities and where the gaps are. So maybe we can talk just a little bit about who these participants are exactly, and why you're using this literacy questionnaire rather than those with lived experience of the service use in these facilities. So maybe it's just maybe it's something that I'm not understanding. Let's talk about it sort of in the feedback. So I wondered that your service users could potentially be individuals who have you know, common mental health conditions or symptoms thereof. Maybe it's their informal caregivers or their family members, because they also support service users and often attend these facilities with them, so they might have some insights. And then of course you've got the healthcare worker perspectives as well. So yeah, maybe we can talk a bit about that. Then I think one thing you can perhaps consider is just reducing the number of meetings that you want participants to be involved in. So you say the researcher will contact the facility gatekeepers to set up a meeting to introduce the study and ask for access. And after access has been granted, there will be a meeting to introduce the study. So I think that's perhaps a little bit meeting heavy. Try to kind of streamline it. I wondered, yes.
Sorry, Bowman, you're giving lovely detailed feedback, but I think we're a little constrained. So I know you always send us lovely feedback in words, so can I ask that we just kind of wrap this up, and then I'll give Dr. Ms Lesley-Ann a little bit of time to respond.
Sure, thank you.
Thank you very much, Doc. I think I'm going to address 2 questions because of time. The other part, in terms of the third objective, where I spoke about community members, I think this was didn't change it in the initial proposal. So this was an error from my side. It's actually health service users and not community members. And definitely, thank you for the feedback in terms of who being included in the study. So the initial thinking was just people who have knowledge, but I think for the feedback in terms of including people who actually are experiencing living with healthcare conditions, I will definitely take this in consideration as a supervisor.
I just have one question because I have insider knowledge of the protocol.
Can you tell us a little bit more about the case vignettes and what sort of models you will be presenting in the case vignettes?
So we're thinking that the case vignettes will be modeled on, for example, a healthcare service user who is receiving an intervention and then from political intervention using the task shifting approach. So this will give the participants some knowledge of what we are trying to happen. We are considering other models as well that are not so maybe familiar. For example, telehealth. What we're able to think about to help the participants think more broadly of how can they receive mental health.
All right, so now we have Dr. Nchangwi Cynthia Munung, who's going to be talking to us about her project with people living with sickle cell disease.
Morning, I'm Shangi, and the topic of my MPhil is mental health occurrence, determinants, and support needs of persons living with sickle cell disease in Africa. And the aim is to address critical knowledge gaps on the mental health challenges faced by adults living with sickle cell disease. So as a way of background, sickle cell disease is a genetic blood condition. It is a global public health issue, but Africa disproportionately bears the burden of sickle cell disease. So you can see the countries with the highest prevalence of sickle cell disease in red. And of the 120 million people living with sickle cell disease, 66% are in Africa. And on the other side, where you have the African map, you can see that 1,000 children are born with sickle cell disease every day. And 90% of these children will not live to see their 18th birthday. Sickle cell disease is diagnosed by the time you're 2, and over their lifetime, they will experience chronic pain, acute anemia, and multiple organ complications. So that figure there just shows the different organs that are affected over time for persons living with sickle cell disease. And they also, so because of these different complications, persons with sickle cell disease are often on pain medication. They are in frequent need of blood transfusion due to the anemia. And they also experience frequent hospitalizations because of the nature of the disease. So what this means is that they experience high financial hardships from the high medical costs related to their disease, as well as disruptions in education and work due to illness-related absenteeism. And I show you this not just to talk about the disease, but also because much of these will inform the measures that we will be considering for this study. Psychologically, also, they experience distress, sleep disturbance, and social isolation. And this is compounded by the social experiences of stigma, which could be internalized and external, as well as discrimination at different socio-ecological levels. And that figure there just shows you the different types of stigma and discrimination that they experience at the individual level, at the level of their family, communities, and school and work. So again, the idea is, the aim is to give you an idea of the measures we will be considering. And so it's actually a condition that has been neglected for long, not much funding goes into it, but some work has been done to address some of the burden of sickle cell disease in Africa. And I really just want to highlight the Sickle in Africa Consortium, which is establishing and expanding on the sickle cell disease registry across multiple African countries, which you see there in red as well. And I show them because it's the work I like to do is informed by my involvement with patient support groups within this consortium. And I also show you the standards of care guidelines that have been developed by the consortium, because it's quite a comprehensive standards of care guidelines. But what is conspicuously missing there is the mental health care. And this is despite that the patient support groups within the consortium have mentioned that that is one of their biggest challenge. And the feedback, so this standards of care guidelines has a home-based version, and the feedback they got from the patients was that mental health care is not supported. But to be fair, perhaps they didn't consider it because of the near absence of mental health services in most African countries. So we will leverage on this for our data collection, and I'll talk about that later. So mental health in sickle cell disease is an overlooked crisis, and I think that by now you know a bit about sickle cell disease. But the gap we want to address is, so first I say that sickle cell disease patients will frequently mention that they are very concerned about their mental health, but there is very limited data on mental health outcomes for sickle cell disease across the world. It's even worse for African countries. And the existing studies are mainly in the US. There are very few anyway, and small scale studies. So to address that gap, we plan to investigate the occurrence, determinants, and support needs and for mental health issues among adults living with sickle cell disease in Africa. And we have 3 objectives. The first is to determine the occurrence of depression and anxiety in adults living with sickle cell disease and their mental health support needs. The second is to examine the association between depression and the clinical and psychosocial experiences of adults living with sickle cell disease. And the third is to focus on anxiety. So this is a study. The study design would use a cross-sectional observational study, and data will be collected through an online survey. And the survey will be developed using validated mental health assessment tools, which I will show you in the next slide. And our target population is adults aged 21 years and above living with sickle cell disease and resident in Africa. And the reason we've chosen 21 years is because in some African countries, the legal age of adulthood is 21 and not 18. So I promised to show you the measures we'll use, and this is it. So we will collect some demographic and information, pain assessment, experiences of stigma. We'll use a specific, the measure of sickle cell stigma tool, substance use, psychosocial stressors and coping, as well as a measure for depression and anxiety. So the questionnaire will be based on these different tools, and we hope to have it in both English and French to cover a majority of the countries. What's our recruitment strategy? I mentioned to you the Sickle in Africa Consortium, so we'll leverage on that consortium to access our patients. So they are establishing a sickle cell disease registry across more than 14 African countries. So we will use that network. I'm also currently working with sickle cell disease patient support groups in 14 African countries. And so we would use their network to collect data. Of course, we'll use social media. And when we attend sickle cell disease conferences, we'll try and advertise that. So hopefully get something. In terms of data analysis, we'll do descriptive statistics. And then to identify determinants of depression and anxiety, we will do logistic regression analysis, and we have 2 models, one for depression and one for anxiety. And I must also say that this sounds really strange to me, but I've been informed that I will get there, and I believe Okay, in terms of ethical considerations, so we will get, before the start of the study, ethics approval from the Faculty of Health Science Research Ethics Committee at UCT. The consent will be digital. It is an online survey, so it will be embedded as part of the questionnaire, and they will only access the questionnaire after consenting. Confidentiality, no personal identifiers will be collected. Data privacy, we will be using red cap, and the data will be stored in encrypted UCT servers. And we would also provide a list of available mental health support services so that at the end of the questionnaire, if someone would like to get support, they know where to get it in their different countries. Dissemination, we would use the checklist for reporting results of internet e-surveys when we report the results of the study. In terms of the academic outlets, so it's the publication thing and the conference presentations, but I'm really particularly keen on giving lay summaries with the sickle cell disease support groups, because I think this work is mainly informed by their needs. I want to thank Claire and Kat for all the support, and thanks for the Amaru Fellowship as well. I think I'm really grateful to the sickle cell disease support groups, because what I want to do is primarily their knowledge. It's informed by their work, and I think that they will be very grateful that there is an opportunity and avenue through Amaru to address a concern that is very close to their heart. And many thanks to all of you, my classmates, and Songawa especially, for taking good care of us during this time. And yeah.
So much, Njangwe. Again, a lovely presentation. Thank you to the audience for being nice and supportive, both online and in person. Okay, now your reviewer is in the room. Ashraf, ask you a few questions.
So I'm both a reviewer and a timekeeper, so I need to watch myself. This was a really lovely proposal to read. I was thoroughly enchanted by your writing, and I thought it was really well put together. I'm also aware that health psychology on the continent has great potential for development, and I think this proposal represents an example of a really good health psychology study, in addition to being within the scope of public mental health. So this is a really welcome piece of research. So I've got a few comments which should be taken in the context of what I just said. My first comment is the title. In Africa. Africa is a big place, and I was wondering, is it really feasible to make statements about Africa, given the large size of the continent, the complexity of people, the different countries, cultures, etc. And I was wondering if there's any possibility to rescope the study and confine it to the places where the data will actually be collected, because in all likelihood, you're not going to get a representative sample of Africa, so to speak. So that's my first comment. And then a second comment has to do with the terminology. When I was reading the proposal, you talk about the occurrence of depression and anxiety. So it would clarify matters, I think, if you were specific about what you mean by depression and anxiety. Are we referring here to caseness for major depressive disorder as determined by a structured clinical interview, or is it elevated scores on a self-report measure, which is not a diagnosis, but presumably the probability of someone having major depression or generalized anxiety disorder? So maybe referring to elevated scores on these instruments to clarify what exactly it is you mean by anxiety. The term like occurrence is not, to my knowledge, typically used in public mental health. People talk about prevalence and incidence. And if that is what you're trying to do, maybe focus on that. In the hypotheses, in the aims, you refer to psychosocial experiences of adults living with sickle cell. The term psychosocial experiences, the way I read it, was a little bit vague, and I was wondering if you could clarify and be a bit more specific about exactly what you mean by the psychosocial experience. You make it clearer as you describe the measures, that becomes clearer, but maybe in the aims. One of the important issues, though, is the absence of a theory to guide your analysis, to guide the actual study. So why should there be any kind of relationship between all of these variables that you're seeking to measure? Why should that be the case? If you can provide some kind of rationale, some kind of set of reasons, some kind of theory that would inform the way in which you will then proceed with the analysis. The psychometric properties of the scales weren't provided, and I'm assuming you'll get there in the next version of the proposal. But this is, of course, extremely important, the reliability, validity, the conceptual relevance of the instruments pertaining to the population that you're going to study. And that brings me to another matter, which is the translation of these instruments, because you're going to be collecting data in French as well. And the question, there's a whole technology about translation and back translation. And even that is not usually sufficient. One has to recalibrate these instruments to determine whether they are actually measuring the construct of interest in that local population. So maybe that's something to consider and discuss with your supervisor. Okay. So the multiple linear regression model, you mentioned that you probably still need to read a bit more about that, but just to say, if you don't have a good theory about why you're doing this, it may be difficult to determine which variables you enter at each step of the regression. And so having some kind of idea behind that would make it a lot easier. In general, crude empirical studies are less preferable than theory-driven hypotheses. Okay, I think I'm going to stop there and hand over to our chair.
Yeah. So and thanks, Ashworth, for the comments. So I think much of it needs us to make some changes or addition to the protocol, and we will do that. I also know the regression analysis thing. I was trying to get out of my comfort zone. At some point, I said I'll go back to qualitative, but stay there. So we'll read that. In terms of Africa, which is what I want to respond to, I think we talked about it's not a homogeneous continent, and that we are aware it would be a limitation of the study. But in terms of feasibility, if we want to do it for 16 African countries, it may be challenging if we state the countries, because we need to get ethics approvals for all those different entities. It will not be feasible. But what we really want to do is just to have a snapshot of it. It's not to say that just to start generating data on that.
Thanks for the presentation. It's not clear to me how you're going to be recruiting all of these, and they're all going to be filling online. So that already eliminates a lot of people who fit into the category of sickle cell. So you're already slicing off to a better off group who might have better resources and so on and so on. But so my question really is, how are you going to tell people that they must go onto the site and fill in this questionnaire? How are people going to know about it? Are there organizations of people with sickle cell that you could contact and so on?
So we note that as a weakness, the selection bias that's noted. So how we plan to do the recruitment is that Sickle in Africa has a registry in 14 African countries. Those are clinical sites, and then they have satellite sites in other countries. So we are going to use that network, your mailing list, the clinicians that are recruiting. We're going to do that. Then we meet monthly with sickle cell disease patient support groups in 14 African countries. So we'll introduce the study to them, and then they will take it back to their support groups to encourage participation, and we'll try to do much of the work online. But I think really what we want to do is to really show that there is a bigger problem, and hopefully that the Sickle in Africa Consortium will start collecting mental health data as part of the registry.
And just very quickly, you won't know if it's bigger if you don't have a control. So against what are you going to compare the prevalence? Against what are you comparing prevalence? You're saying you want to see if it's higher than what?
No, we don't want to see if it's higher. We want to see if what that prevalent is in that particular population, not necessarily how it compares to.
But it might be the same as everybody else in that.
Yeah.
Question, Maggie? Just a comment about the translation. So the colonial history, the French neglected open language written. And so it's almost impossible to translate into a written questionnaire into the local languages in West Africa, for example. Right. A lot of the Francophone. I think Portuguese may be different, but you may not have Portuguese countries in your English ones. Yeah, the English language.
Yeah, so thanks. That's noted. And we actually
are translations of PhD and get. I just Google them quickly. They are translations in English.
All right, thanks. So we'll note that, and we'll look at the different translations that are available.
Thanks so much, and very well done.
It is now time to take a little break. It's tea time. We'll come back at 11:15. So please go get caffeinated and comfortable. Those online, you can stay online or you can hop off and come back on. That's so many of our PG dips from this year are actually online with us. Enjoy. So now we're going to move on to Ms. Tyla, who's going to talk to us about her study, and this is very close to her heart, and it's been on her mind for a while.
Good morning, everyone. My name is Zodwa Anisbeck, and today I'm going to be taking you through my research, which is the one on the board, exploring coping strategies and support needs of bereaved African migrant adolescents and their caregivers So the rationale is that maybe to give you a background is that in 2023, State SA released a report, an immigration report that stated that about 4.2 million migrants in South Africa, and which is about 7 million people, 7% of the population, and most of them from the African communities are from Southern African region, and they chose South Africa as their home because of a lot of opportunities like stability and also a hope for better economic opportunities. And then now with migration, there is also the element of adolescents, who are usually most of the time termed as trying to find their self. They are changing from being children and then on their way to adulthood. And now with bereavement in migration, that's where I am. And I want to find out firstly the areas to support. And I also want to find out the disruption of traditional grievance practices and caregiver challenges, as well as the limited cultural appropriate services. So basically with the review that I've done, we have found that all the things that I've mentioned here they are actually existing in these communities where, because of perceived stigma, it's either they report late at healthcare facilities or they don't report at all, where they end up using informal service providers to access mental health care. And many of them, they end up not being diagnosed of any mental health challenges. And with the disruption of traditional grieving practices, most of them, they rely on their community, where if maybe there is a death in the family, they gather around, they support the family, families as well from far, they come in to make sure that they support the family. But now finding themselves in a different country, they don't have, they are not able to practice those cultural customs, as well as the mourning period, because they still have to go to work and make sure that they provide. And caregiver challenges. Most of our adolescents, they rely on their caregivers to make sure that they offer support. They also make sure that they guide them through the grieving process. But at times, if maybe it's a close family member that has passed away, the caregiver find that maybe they are also grieving as well. And also because of a lot of different cultural backgrounds, there will be a lot of things that will interlink with the grieving process. And for limited cultural appropriate services, most of the times because of the cultural diversities that we have, most of the service providers that are out there, services, they are not culturally cast to cater for the needs of both the adolescents and also the caregivers themselves. And because of this, what is the problem? The problem is that there is grief that the adolescents are experiencing. And most of the time, if it's not diagnosed or if the grieving process is not guided well, it will end up complicating to complicated grief or even other mental health disorders such as depression and also anxiety. And we also look into the fact of how did the person die? Was it maybe violence where it's a sudden death, or is it suicide, or if it's a family member was actually sick and eventually passed away? And what we're hoping to do is to make sure that we explore and hear what their perspectives are, what are their lived experiences, and hopefully be able to implement, integrate support systems for them. And the aim of the study is to explore the perceived needs and coping strategies of bereaved African migrant adolescents and their caregivers. The objectives of the study is to explore the bereaved adolescents' grief experiences, to explore caregiver support for the grieving adolescents, to describe the coping strategies used by the adolescents themselves, and to identify the psychosocial needs of grieving adolescents and their caregivers. The study will be conducted at the Teddy Bear Clinic, which is located in Johannesburg, at a suburb called Hillbrow. Hillbrow is known for, it's a dense suburb that has got a lot of African migrants living in the suburb, but it's also known for a lot of public health concerns where there is overcrowding, lack of even basic services, but above all, crime as well. And what Teddy Bear Clinic does is that it interacts with the adolescents, so they provide trauma and counseling services to the adolescents, and mostly from the migrant communities. And also they interact also with adolescents that are experiencing bereavement, and some of them that are experiencing grief. So that's the reason why we chose this setting, because already it's going to be easy for us to access them because of other barriers that might be there where others are not going to be able to come through because of maybe documentation and also other things. So for the study population, it's African migrants, and then they have to be residing in Hillbrow and surrounding areas. We're going to be looking at bereaved adolescents specifically, and also primary caregivers. For sampling, we're going to use purposive convenience sampling because we believe that at Teddy Bear will be able to sample a lot of the adolescents, because in a month, they usually see about 800 to 1,000 adolescents. So there's really a demand as well for the work. And also that's where some of us will come through to volunteer in these organizations, so that there is also an element of relief on the service providers at the center. And then for recruitment, it's going to be at the foundation, and then adolescents already receiving counseling services, and then primary caregivers of the adolescents themselves. But for the primary caregivers, I will take you through a process where for us to be able to reach them, we are first going to make sure that we reach them via the adolescents that is going to be in their care, because there's going to be the first point of contact. When they are coming through for a counseling session, they are going to be screened for complicated grief using the PG-13. And then when they meet the criteria, we're going to ask them if they allow us to contact their primary caregiver, where the study will be introduced. But before even doing that, we're also going to make sure that we advertise the study itself at the center, so that the primary caregivers themselves, when they're coming through for Parents' Day, where we do awarenesses on how to identify any mental health challenges and only withdrawals in their children's lives, they will make sure that they have a full view of the posters that are going to be put at the foundation. And then for the inclusion criteria, we are going to be looking at adolescents between the ages of 10 to 14 and are proficient in English. And the reason why we chose English, because it's the language that is being used in Teddy Bear Clinic. And then they have to be African migrants in South Africa, but specifically have lived in Hillbrow for more than 6 months. And then they have to be seeking counseling services at the Teddy Bear Clinic for the adolescents, and they have to score 25 plus on the PG scale. And for the caregivers, they have to be primary caregivers of the bereaved adolescents. And now they have to be either staying with the caregiver or maybe caring for the adolescent for 5 days or more in a week, so that we'll be able to catch a lot of context on how their experiences with the caregiving role, and also be willing to participate in interviews. And for the adolescents, the exclusion criteria will be if maybe they've got an existing mental health challenge that might actually trigger them more in participants in the study, they are going to be excluded. We are also going to exclude caregivers that are not actively involved in the adolescents day-to-day, or they're not responsible in their day-to-day life. And for the research method, we are going to use the qualitative, exploratory, and descriptive approach, just to make sure that we capture all the experiences and all the narratives that they are going to give us. And then the correct guideline is going to be used to make sure that we ensure the rigor. And then for Rexivity and member checking, we'll make sure that we implement that. This is especially going to be important in my context as a researcher, because I'm involved in advocacy in the area of health law, and also to make sure that whatever my views are, they do not affect the research. And for data collection, we are going to use individualism structured interviews, 45 to 60 minutes, conducted at convenience time at the host institution that we believe is going to present that safe environment for them, because they are always attending and the parents are also familiar with the setting. For data analysis, we are going to use the thematic analysis for Brown and Clark, and then separate analysis of caregiver and adolescent data used for systemic coding using NVivo. And then we make sure that with my supervisors, we ensure that there is intercoder reliability by using the Coinscaper measure. And then finally, for the ethical considerations, we are going to make, I have divided them into 3. The one element of informed consent, the one for safety, which we believe will be important, and integrity and knowledge dissemination. So we'll make sure that there is a process of voluntary participation where they will know that participation is voluntary and they can withdraw at any time. And we'll make sure that there is anonymity of participant identity and group confidentiality, to make sure that when they're coming through for these presentations, just to maybe to make sure that they are safe, because of some of the areas can be at times very violent towards the migrant. We'll make sure that they are safe, and the protection of the population. For physical and well-being, physical safety at the foundation, and then a protocol for distressed participants appropriate referral and support. And we make sure that because of my involvement at the foundation, I'm going to recruit 2 research assistants. We make sure that they are trained thoroughly and that they know the scope and they also adhere to the protocols that we have in place. But above all, debriefing, data storage, and make sure that there is appropriate dissemination of findings and distribute findings to key stakeholders involving and also the migrants themselves. Make sure that their experiences were captured well. Thank you.
Thank you. Well done, Sandra.
Thank
A really
you.
interesting study. So Prof. Desmond Painter from Stellenbosch is going to give you some comments. Could you stand there close to the people online are very keen to hear what we're saying.
Hi, I'm Desmond. I'm from the psychology department at Stellenbosch, as Grace said. Firstly, it's a very good presentation, very thorough, and so on. And also really enjoyed reading which I thought was very clear and well conceptualized. And it's very clear for me to see basically what it is that you wanted to do. One of the things that, firstly, it's something I guess I sort of by default always say to students when I have to evaluate a qualitative research proposal, is I always wonder about the scope. And I understand conceptually why you are looking at both what you say the coping strategies and support needs of the actual bereaved adolescents and the caregivers, because you are interested in sort of contributing to the nature or the quality of care that people get, right? But it does seem to me kind of, although conceptually I understand, but it does seem like a big thing to study both things. I don't know how huge so I flagged that. I'm not saying you shouldn't do that, but it does seem to me quite, it can be 2 separate studies, to look at the support needs of the adolescents and to look at the caregivers. Right? And also, even if you do both, I was wondering, it seems there's a little bit maybe in there's maybe a lack maybe of a kind of theoretical lens, because they seem maybe separate enough for me, the kinds of things that you want to know from the adolescents and the kinds of things that you want to know from the caregivers. I think they would be different kinds of things, the actual bereavement in that sense, or the support. And that doesn't come through for me exactly what it is that you're going to ask of, find out about the adolescents. And the caregivers, besides sort of more general sort of things that are coping strategies and support needs, which are quite generic sort of kind of psychology type terms, right? Now, and then to jump back, so one of the things I really enjoyed about the proposal is what you introduce at the beginning, actually part of your context, but it does reveal a kind of cultural psychological sensitivity, I guess. So you say that that mourning is something that is structured. It isn't kind of individualized, right? It is something that is that becomes ritualized and sort of experienced within a kind of community with particular kind of set practices and so on, whether people are aware of it or not. That's how it's sort of enacted. That makes it possible for people to navigate the mourning process. And the great thing that you recognize is that becomes disrupted by the migration experience. So it's not just that, people are bereaved or it's very intense or something. It's something specific that happens, which is a kind of interruption. And that interruption you can find, in the move from traditional to modern societies and so on. That happens, but this is an intense kind of disruption of not just networks, but practices and all sorts of things. I think that's a great insight. And one of the things then that comes to the fore is that when you talk about is that you actually want to understand how these adolescents deal with grief and bereavement in the absence of or within this disruption. And that's a really interesting thing. I think that's a kind of in terms of cultural psychology, so that could be theoretically to try and find theoretical terms to understand that kind of collective community kind of infrastructure sort of the emotional stuff, right? And you do that well, and that you should hang on to that. But I think, but when you translate it into the kind of academic language then of strategies and support needs and so on, that kind of individualizes it, right? So now you're talking to someone and you ask them about their needs and so on. It's not necessarily that you might not in those interviews really then capture how exactly do they navigate the contradictions that are created by this disruption. Because now you already sort of impose, to some extent, kind of psychology framework, which itself, psychology kind of tends to deal with these things in a kind of individualized way. It's kind of individual process, journey, and so on. And part of the problem is, of course, that it's not. It's a long story, sorry, but I'm thinking if you could get some kind of theoretical lens that keeps that communal thing, that which is disrupted, alive in an interview. At this point, you don't say really what kinds of things you're going to ask in those, but that the interviews don't simply then become individualized things, so that this potential contradiction that you talk about becomes invisible, and you only ask people about their feelings, their needs, because then you might end up with very generic kind of people have similar needs, maybe more intense here. So I don't know if that makes sense. I can't think of any kind of specific theoretical lens. I'll think of something when I send you the wording. But to me, that's something that I think is important and living in the proposal. It can be sort of made sure that you go through. And there I wondered whether, I'm thinking about the kinds of questions one would ask, even like incorporating some kind of, if you do incorporate the caregivers as well, some kind of observational elements or diary kind of elements to look at the way that certain practices or these things that are disrupted, how that is compensated for beyond the kind of conscious things that people say, this is what I need. So I was thinking maybe methodologically, even going beyond simply a kind of interview, but some kind of observational diary or which I will write more about in the Word doc.
No, thank you so much.
That's probably enough for now.
Thanks so much, Desmond.
Suggest that it's too much, but
it's perfect. So, would you like to respond to points?
No, actually, I just want to say thank you for the valuable input. What I'll do is that will incorporate them and make sure that with my supervisors we try and.
You don't have to incorporate anything I say, but
we'll try and make sure because they're valuable. I'm sure they'll agree. But thank you so much. Thank you.
Good luck.
Thank you so much.
I think we're out of time. Thanks, everyone. Well, Mr. Alexa, it's going to really step up. I just want to quickly say, I know the room is quite hot. I came in early to switch an egg on once, but it may not be working that well. If people outside want to have my chair or move across, please do. There's standing room at the aircon as well.
Thank you.
Over to you.
Good morning, ladies and gentlemen. I'd also like to thank the person who organized the presentation because my presentation flows well with what was in terms of the cultural aspect. A bit of my background, I'm a psychologist working in community clinics in Khayelitsha and in Somerset West. And then in my work, I've been trained in the Western ways and encountered quite a number of patients who during my interactions presented with cultural things that I feel like I am limited. And then also when you're listening to the patient's narrative, they speak of family members who are experiencing some psychological distress, but would not come for therapy, would prefer to go to sangomas or other people of culture. So it is now then that I wanted to explore the perspective of mental health care practitioners who are also certified traditional healers on referral pathways for mental health care users in primary health care. So the previous speakers have clearly articulated the prevalence of common mental health conditions in South Africa and in the world. But I want to specify that even though the budget still goes up on in terms of specialists, we still don't have enough. of specialists. And as a result, many patients do not receive evidence care treatment. When looking at doctors or Western trained physicians versus doctors, it is clear to see that there's an abundance of traditional healers, and therefore they are a useful tool that we can utilize in terms of bridging the wide gap that is widening in terms of provision of mental health care. And we know in terms of the financial constraints now, and people who work in the public sector, the budget is becoming less and less, so we will have to do what we have. And then one of the methods to deal with the widening gap has been task sharing. And then also in task sharing, they do include indigenous and traditional healer in terms of providing the services. What is nice about traditional healers is that they use indigenous knowledges, practices to inform treatment of the population that they use. They use local herbs, ceremonies, consultation with their ancestors. They are relatively cheap. A traditional healer will not turn you away if you don't have money. And in some instances, when you don't have money, you pay after you've healed. And then also importantly, in terms of mental health, there's quite a lot of stigma when it comes to mental health, but patients who go to traditional healer report less stigma. In terms of collaboration between the two, the Western and the traditional mental health, that has been a challenge. In most of cases, it will be traditional healers who will be trained in this Western method, such as seen here in this picture. But it's never the other way around, where Western trained practitioners learn and refer to traditional healers. As such, the referral system has been unfair in that it has been one direction, with traditional healers referring to the Western trained practitioners. In particular, Western trained practitioners have undesirable attitudes towards traditional healers about their methods. They worry about ethics and also harm for patients. So then it makes it difficult for them to refer. And also, obviously, when the issue of merging is being looked in research, they either look at traditional healers or Western trained practitioners. So then each profession would advocate, for its superiority, but then, there would be no good ideas in terms of merging. So this has been quite difficult to do. It is now then that we want to look at persons who are both the traditional healer and also Western trained, for them to offer a qualified opinion to avoid medical pluralism, where it is a term where one patient would use the Western trained, Western healing methods, and then also traditional. Although there is some evidence that helps, but in some cases, it might be harmful, especially to patients with mental disorders, and then also for adherence. So we want to answer this question, and we will help that it will help us to explore the perspectives on effective and equitable referral system, and then also barriers to equitable referral, and also some recommendations in terms of an equitable referral approach, and also to identify which conditions can be treated by Western or traditional healers. In terms of the research design, a qualitative research design will be used, and then phenomenology will be the lens that will guide the researcher in terms of theory. After applying for ethics from the University of Stellenbosch, I will then recruit patients using snowballing sampling approach. I will give them a flyer or an information sheet I will forward it to the circle of people that I know that work with people who are both traditional healers and also Western trained, and I will send it to them, and those who agree to participate will then contact me, and then I will arrange a time that is suitable for them and me to meet. Only English-speaking healthcare professionals who are registered with a regulatory body and also are certified traditional healers will be involved in the study. So it will be a wide, broad range of category of cadre of staff from OT, social workers, psychiatrists, psychologists, and the like, but only people who work in mental health care in South Africa. In terms of the study procedure, after they have contacted them, I will explain the study, and then a date and time will be arranged that will be suitable for the both of us. And then before the interviews commence, I will explain the study, and then they will have time to ask questions. And then when they are satisfied, then they will sign a consent form, and then audio recorded interviews will then commence, which will either be online or in person. And then I will use an interview guide, which will be a semi-structured one, to guide me through the process. And then in terms of sticking with snowballing, at the end of the interview, I'll ask participants if they know any other people who meet the criteria. Thematic analysis will be employed in terms of data analysis. And after the transcription has been done, the audio recordings will be destroyed, and then the transcript will be kept at a university for a number of years as determined by the university. I'm quite new to Stellenbosch, so I'm not aware of that. And this will be for purposes if perhaps other people want to use the data for systematic reviews. Obviously, this will be communicated on the consent form. And those who do not agree, then their data will not be. So then in terms of trustworthiness, I will, with my supervisor, review themes, engage with my supervisor. I will have a reflective journal, which I will keep a recording, and then also in terms of confirming with the themes, and then every strategy that is done will be in consultation with my supervisor. I will also, I will also take all reasonable steps in terms of analyzing data to make sure that my data analysis is consistent with the study design, and that also the findings that come about are because of what the participants have said, not that of my own. In terms of transferability, all the details and steps about the data will be documented, including the sample size, setting, context, procedure, and then also the interview guide, the inclusion and exclusion criteria. I will be as reflective as much as possible. I'm aware of my own influence that could happen in the study, as also I'm a Black African who's trying to advocate, for the use of diverse other healing methods. So it will be noted down as a limitation if that happens, but I'll try to be as reflective as possible, and then I will document any limitations, including if I include people that I might have had prior relations with in the study. In terms of benefits, obviously it is going to help in terms of bridging this gap, this wide gap in terms of merging the two, I hope. And then also, obviously, we'll thank participants for their time. Unfortunately, we do not have money for this study, so there will be no any other rewards. Privacy and confidentiality will be maintained. No identifying data will be included. And then also the data will be locked somewhere in the university where it's password protected, and then also I will only have access with my supervisor. If it comes that some participants experience emotional distress during the interviews, they will be referred for counseling. Yeah. Thank you very much.
Great, thanks so much, Lisa. Well done. Fantastic presentation. I love your use of images and you're a great storyteller as well. Can I say, no, you can, I think you can sit you close enough. So Dr. Carrie Brooks-Sumner from the SAMRC is going to give you.
Yeah, great. Thank you so much for this great presentation. And I must say, I really enjoyed reading your proposal. So I think it's getting to the nitty-gritty of a really important issue in South Africa. As you say in your proposal, there has been research in this area before, but there's this big gap that is still sort of present. So my comments are, some of them are very high level and some of them about feasibility. So one comment which you and your supervisor probably won't like at all, but I'm suggesting that could there be a space for slightly reconceptualizing what you're trying to do here? Because I think you're focusing on the referral pathways, which I understand as a clinician, that's, you know, where you see the potential for impact. But in fact, the people that you're interviewing here or you're trying to find have a lot more to contribute than just sort of talking about that. So what they could do is they could tell you about how they bridge that divide for themselves. So they're sitting with their feet in both of those two areas. And I think that would be a really sort of interesting contribution to the literature to talk about how did they actually reconcile it for themselves, if that makes sense. So that their lived experience of being in both the Western and the African traditional practicing areas of practice. So that's kind of a big one, and that'll take you back a bit, but something to think about. And you could just sort of change your topic guide to ask more broad questions. So then my other question is a practical one. How do you know that you're going to be able to find these people? So the snowball sampling is fine and all of that, but do you have like a good idea that there actually are enough people that you will have access to, that you'll be able to meet these criteria? Then what else? Yeah, I think so. There's a lot of issues that you need to unpack around the traditional healing practice. So you do mention that, you know, there's herbalists and then there's people who do work with ancestors and that kind of thing. But the way that medical practitioners would relate to those different types of specializations would be quite different. So, for example, the issues with herbalists is that they sometimes prescribe emetics that, you know, impact on other medication. So I think you need to be clear about really what type of practitioners you're working with and what are some of the real specifics of their practice that you're trying to understand. And what else do I have? Yeah, it's such a big, interesting field. So I wanted to also understand, are you talking about medical doctors in primary care specifically? Or when you do the snowballing, are you going to, is it going to be, you know, could it be people who are nurses? Could it be people who are other kind of health professionals? And then, yeah, what do you think about, so the way you're doing your sampling and recruitment, I think is probably the only feasible way that you could do it. But you've also got to think about what are the potential issues around bias. If it's people that you know already, who you're asking to come and be in your study, and then they're also referring other people. So those are just some of the things to think about. But overall, I think this is a really interesting study. I think whatever happens, you have to make it into a publication. And yeah, and good luck.
Thank you very much, for those comments. So in terms of finding the people, as I said, I'm part of a group, on self-psychology and spirituality. So there are people who are working with both. For example, we have a clinical psychologist with the Sangoma. So then they also know other people who are quite similar. And through my conversations here, also, I forgot his name because I'm never. Also mentioned that he has had, a colleague that he's working with as well. So I think if then the pamphlets or leaflets are disseminated, then there is a potential to get other people. I do believe that there's quite a number of those people out there. We're not only looking at the doctors, we're looking at the wide range of healthcare practitioners who are working mental health, not only doctors, but psychologists, social workers, OTs, everyone who's working in mental health. In terms of packing traditional healing, that is a big one, and it's an area of continuous growth, for myself. And I think, it's quite broad, and it would be too big if we dive deep and go there, to the specifics. But I think it's something that I will obviously speak with my supervisor and see how we can provide as much detail in terms of the people. Also, because of my sampling, for the presentation, I don't know which one we will get, because of the scarcity of the people that we add. So I'll be taking, what comes around. So I don't want to say that I want to include certain people, and then I don't get them. In terms of bias, obviously, if there is really a difficulty to get people, then I will obviously look at people that I know, and then I will not the presentation. Thank you very much.
Okay, we have 1 minute. Question.
So I haven't read your piece, but going with what I listened to, and I think this is true. So this is what the I don't have answers for you that I want to ask you, but I think maybe a difficult question. If you think when we do studies like this, so I've been reading the whole study that we've done at UCT quite a bit, published in transcultural psychiatry. What they tend to do is precisely what you do. And I understand why we do it. So we write what you're saying, we write from the perspective of the mental health services, we write about. So it's what I'm looking for, not superiority. The perspective which you run, because you're part of this one system and not the other. And that's what they were doing. They would use a phrase called idioms of distress, which I really like. But even if they say so, they want to integrate, we want to integrate the services into what we do. So the question is there a way to do this that turns the world upside down? Because the world we're living in privileges for us to Euro-American sort of when we train with things. So the question to you is, perhaps you want to take a bit more time with the psychology and think about not reproducing this world. Because the idioms of distress are really an important way to think about how you can have these services that exist already, and they do something quite good for where spirituality, whatever. So this is a potentially really good piece of work. If you were to do an upside down world, or the world is already upside down, like people in Africa tend to support a world that makes their world subservient, and you're reproducing that, not deliberately, but because of getting caught up, right from the language we use to when we think about our studies. And I think a little bit about that the world in which we live is in an odd way feelings and all this. So I don't have answers for you, but I'm thinking, when I think a little bit how to restructure the work that has the potential to be really good and make contribute rather than just reproducing the work as it is.
Yes, thank you very much, Prof. I was hoping that would be late because I knew you'd ask these questions. I spoke with Majalifa. So in terms of responding to that, I think this will be an upcoming study with Prof. We did talk about idioms of distress in detail, and then there's something that we are going to in future. For me personally, even the idioms of distress are quite limiting because it's a translation of the terms into the language. They do not speak to spirituality. They do not speak to other ways in terms of how people understand stuff. It's only in line with the Western trained practitioners. So, you know, that is a limitation that I'm noting. So the work that I do, I'm going to do, I want it to be broad and also encompass spirituality because as Black Africans, we are quite spiritual. So I'm thinking, I'll be thinking about your what you suggested. Thank you very much.
Then if you want to stand up and stretch a bit, I feel like our brains are quite full from a lot of interesting studies. I almost want to empty mine out a bit. While the next speaker comes up.
Yes, goodbye.
Yeah, one minute.
Everybody back to sleep that was supposed to. It's not a I think there's a lot more. But there's a lot more conversation. Yeah, I think there's quite a few people you would love to have further discussion on a number of these topics. So thank you all for your engagement. And I'm now going to hand over to Dr. Mojalev Mahata for his presentation.
Good morning, colleagues. And yeah, and maybe even before I start, you know, sometimes as I'm sitting there, I was feeling like I hope our colleagues know that I've only been here for 3 weeks. So I suppose, yeah, the comments and the feedback obviously is well welcomed, but we are only colleagues. Without wasting time, my topic is prevalence and factors associated with frequent rehospitalization among male psychiatric patients at a regional hospital in Sidibeng district, which is supervised by Prof. Ratele. And this is more or less what I'm going to cover, and we'll try to use a little bit more time, especially around the plan of inquiry. In terms of this particular topic, I think what is important to note is that, like, you know, frequent hospital readmissions of mental health care users in psychiatric settings is a public mental health concern. And when patients get readmitted frequently, you know, it places a huge administrative and economic strain, not only on the health system, but also on clinicians and families as well. And the literature defines frequent rehospitalization as a period when patients get readmitted at least once within a 12 to 36 month period after or following first admission. And the prevalence of these readmissions, the range of it's around 5 to 20%. And young adult males in particular are reported to be the ones who are most likely to be frequently readmitted in hospitals. So obviously, I won't go into the details, but there are quite a number of factors as well around that, why specifically young males. And the factors that are associated with frequent hospital admissions, they range from, having a severe mental health condition, whether it's using substances, whether it's having a history of involuntary admission, or the short length of stay in hospital where, because of, I suppose, the pressures that comes with our public health system, where patients would then be admitted for shorter periods. And in terms of the rationale for the study, that when I've scanned the literature, what becomes clear is that like a lot of these studies are concentrated in high-income countries where we have literature either in South Africa or the continent. These studies are mainly carried out in tertiary institutions, which are located in urban areas. And most of the available data as well, it's quite a bit, it's a bit old, which dates back to pre-COVID-19 period, and with a few that took place around that period of the COVID pandemic. And this little scholarship post this pandemic period with mental health condition and hospital was, apologies colleagues, that there is little scholarship post this pandemic period with mental health conditions and hospital admissions are reported to be high post, because when one looks at the data, especially that was focusing mainly on COVID-19, and a lot of those studies do indicate that like there was a lot of of mental health admissions post that particular period. And therefore, the rationale of the study is to investigate the prevalence and factors associated with frequent hospital readmissions in male psychiatric patients in a regional hospital, which is located in a peri-urban context in a low to middle income country, which is our country. And the aims and objectives, the aim is to investigate the prevalence of and factors associated with frequent hospitalization of male psychiatric users at Sebokeng Regional Hospital. And the two objectives of the study is to describe and analyze the frequency of hospital admission in 2 psychiatric wards within a 24-month period, as well as factors associated with hospital readmissions within this group during the study period. Then in terms of the plan of inquiry, the design of the study will be a quantitative cross-sectional research design, and the study will take place at Sebokeng Regional Hospital, which is located at Sebokeng Township in Sedibeng District, Gauteng Province, and the population is largely Black in the area, and the district is also classified as a peri-urban area. And this is the map of Sedibeng. And as you can see around here, it is actually surrounded by Mpumalanga, as well as the Free State province. So a lot of the towns that like are closer, be it your Sasolburg, they do use services in this area as well. So the hospital that I'm referring to is located in a sub-district called MPhil, which you have Midwives here, and this would be the city, which is a little bit much more rural than where the hospital actually is. Oh, thank you. Okay. And then in terms of the study setting, as indicated, take place at Sebokeng Hospital. So this hospital is a regional hospital which offers level 2 mental health services, which has 2 male wards, which is ward 12 and 18, and the bed capacity at the hospital is 73, and the distribution of beds is almost equal between the two beds. And due to infrastructure and capacity challenges, there are no child or mental health services. These users are referred to the city of Joburg, and the female patients are housed at another hospital called Kopanong. So the hospital itself, where I'll be doing the study, mainly has male patients. In terms of sampling, I will use convenient sampling, which will be then I will do a retrospective record review of clinical case records. And in terms of the inclusion or exclusion criteria, like all the records of mental health care users who were admitted in 12 and 18 between January and December of 2024 will be included in the study, and those who were 18 and above during the study period, and clinical records will be included in the study irrespective of the diagnosis of the patient at the time of admission. And in terms of exclusion criteria, users or mental health care users below the age of 18, and it might happen that you find that maybe there might be some users who might have been admitted maybe in December or November before the study begins. So all those users will also be excluded, because you might find that like someone was admitted the previous year, maybe in December or November. So at the time of the study, they might still be in the ward. So those users their files will not be used in the study. And participants with acute mental health conditions who were discharged within the 72-hour observation at casualty will not be included, and clinical records of participants who might have just died during admission will also be excluded. In terms of data collection, I'll use a biographical information questionnaire, which will also be, I'll develop a spreadsheet, and some of the data that will then be used, that will be collected, will include what is highlighted, issues of age, gender, marital status, educational level, as well as psychiatric conditions as well, the diagnosis, issues of comorbidities, treatment. One would include both pharmacological and non-pharmacological, which would include if patients might have seen a psychologist and other therapeutic services. And in terms of the procedure, I will use a IBM SPSS statistics version 27, and this 6-phase process will then be followed, where in the first phase it will include the reviewing and sorting out of files, and then those that meet the criteria will then go into phase 2. Then during phase 2, this is where then all this information will be collected, and phase 3 will include transferring all that information into the spreadsheet that will then obviously be transferred to SSP. Then in terms of data analysis, both descriptive and regression analysis will then be performed. And lastly, data synthesis and summation will be done, and report writing. Prof. Ashraf is showing me things here. I think this colleagues, I won't go into detail concerning that, but I think it's your basics. But maybe what I need to indicate is that, like, you know, any information that has the potential to identify candidates will not be used, and that all the files or patients will then be coded. Then I have a particular system that, like, I will use for that. And in terms of beneficiaries, I think issues of strengthening referrals pathways, training for discharge, and identifying mental health care users who might be vulnerable or at risk. And yeah, I suppose I won't have time, colleagues, to go into the limitations, but maybe just to mention one thing is that obviously one of the study limitation will be the fact that, like, you know, since I'll be using quantitative methods, I think in the process there is always the risk, I suppose, or the limitation that because you are dealing with secondary data, you might not have those experiences of actually users who are getting readmitted into the system. And thank you.
Well done. It sounds like you've got your PhD plan. Okay. I'm going to invite Dr. Roxanne Jacobs to come and.
Well done. I think it was a really good proposal and presentation as well. I don't think you have a lot of work to do with the whole development stage, but I've got some things I'm going to talk you through that think about doing and expanding of the work. So the whole of that. I really enjoyed the work because it's very important. In terms of your rationale, you list the risk factors for the admission. You say that the male population is important to look at. But I think for your full proposal, it will be good if you spend a little bit of time talking about why, in a particular, male population. Any other population cannot. And then you speak about the records that you're going to look at during a retrospective study. I felt it was a bit missing in terms of what kind of records you are looking at. Is it electronic records that you're going to be looking at? Is it physical hard copy files that you're going to be pulling? Is it a combination of both? What does these records look like? What are the procedures involved in actually accessing and collecting more participants when looking at those records? Then you mentioned it in your study limitation. Like you said, the missing records is something that goes hand in hand with doing retrospective. The files will have different kinds of, you're looking at particular variables. So I think just for when you're expanding on a proposal, it would be good if you can specify exactly what those variables are, and if there are standardized forms perhaps in the reports that you can do include specifically. So that might also sharpen your inclusion criteria. Let's say there's a standardized intake form, or there's a mental health assessment that's being done. What are the exact forms that you're looking at, and what information are you targeting from that? So you're looking at not just the admission, but substance use history, violence history, community. Just specify that. And then if you have standardized forms for those, to make sure, to think about how are you going to handle when some of that information is not there. So if you're including records, is there a percentage of complete information in a record that there needs to be before you include that record? How are you going to report about that? What decisions you are going to make about including it to it? That's not a lot. And I've got a document that comes with well of independent variables that you can look at. So you'll send the comments to there as well. But in terms of the data analysis, I think it was a little bit vague. I think it could be a little bit more specific. Once you know exactly which variables you're looking at and what kind of data or variables there are, you can see what kind of analysis you will do. So in the document, I do raise a few examples of certain questions that answer. And then just lastly, the ethics. I think, yes, you're doing a records analysis. I mean, looking back at retrospectively of medical records. But for ethics purpose, I think it's useful if you do mention that you are applying to get waiver of consent. Are you planning to get permission from those participants that you select to use the information? Or are you accessing public records where you are asking an ethics committee or institutional body like the DOH? Can you use that information without getting individual? There are, of course, lots of justifications that can be used in public health papers quite often. But you need to at least just mention in the text justification is asking for that way. Other than that, I think it's brilliant. It's a really good topic. You are very, very close.
Thanks, Roxanne. Thank you very much.
Yeah, without taking much time, a lot of the issues that like you are raising around issues of males, unfortunately, maybe for the purposes of this presentation today, a lot, obviously one could omit so much, but we did discuss it already with my supervisor, and I can assure you that like a lot of that work has already gone into the proposal already. But obviously, I do take note that like perhaps in terms of the argument, I could strengthen some of the arguments, especially, when it comes to the method section, especially the analysis part. I must confess as well, this would be the first time, obviously, I'm working with numbers. So, but I'm well aware that like there is a lot that can be done in terms of how to analyze, all this information that will be gathered. But we have already spoken about it. It's just that a lot of those would not be incorporated, unfortunately, for this presentation. But we take note of it.
Thanks. So you see much about the sign language. Thank you. Maybe you've had a few different translations of thank you. We had Miyaka earlier from Shangri. Okay. All right. Let's move on to our next presenter, Mr. Lebanon Valete.
I guess I'm the first one to say good afternoon. That's how long it's been. Endeavours the longest among all my peers. Please be considerate. Okay, I'm not going to use them. So my name is Lebo, and I want to talk to you very briefly about this topic on the screen, an exploration of the psychological, cultural, spiritual, and social needs of family caregivers, of people living with dementia in Johannesburg, but probably will limit myself to two townships in Johannesburg, and we'll talk more about that. So instead of going into the big background, because there is, I'd rather just talk about the rationale, maybe in just 3 segments. So what do we know about dementia? And it's very broad. First of all, we know that dementia is a progressive neurodegenerative disorder that impacts, and adversely for that matter, people living with dementia and their caregivers, and I call them CGs from here. They are normally referred to as the silent second patients because they are they are hidden away from society, not just people who live with dementia, but caregivers as well. So that's important for me in this study. And we also know that dementia remains underdiagnosed across all South African communities, but more specifically in the Black African community. And culture has is a factor and plays a role in it. We know that there's stigma, well documented, there's caregiver burden, and this poses often a risk, that's physical and mental in terms of caregivers and their families. What is unknown up to so far, at least in the South African context, is how culture, more specifically, and spirituality impact Black African caregivers. And some of my colleagues have mentioned one or two aspects about that and their mental health. And that naturally has created a knowledge gap. And we know that there's very limited research on the actual experiences of caregivers in Johannesburg townships. Some work has been done, good work, but very limited. I think quite a bit has been done on a Soweto suburb, but it's just limited to just one aspect of Soweto, and I'd like to take this even deeper. So also, there isn't much that we know about how caregiving for Black Africans is rooted deeply in social, cultural, and spiritual expectations that are posed on them by society. And also how expectations that are posed by culture don't often give support to these people who are caring for people with dementia. But also there isn't much support from the public health system, and that has been mentioned before by one or two of my colleagues. So my aims, there's one aim essentially, and a couple of objectives. I want to explore the psychological, cultural, spiritual, and social experiences and needs of family caregivers who look after people living with dementia in two townships, Alexandra and Soweto for now. And that has a couple of objectives, and one is to explore the actual experiences of caregivers as they support their loved ones who live with dementia, and to also understand the psychological, cultural, and I've mentioned before, spiritual and social needs of these caregivers, and also to describe the availability of support services, either in the community or in the public health system. The methods that I've opted for is, first of all, I want to do an exploratory qualitative study. Lends itself to many benefits. One is it affords me an opportunity to do an in-depth understanding of the lived experiences of caregivers. And it offers a great flexibility. The group that I am going to be targeting might require a whole lot of flexibility in data collection. And I'll speak more a little bit about that later. And exploring that study, qualitative study, affords me an opportunity to explore a relatively understudied, unknown context, not just the setting, but the concept and the people that I'm targeting. I'll use the analysis for meaningful patterns, and the qualitative study aligns very well with thematic analysis in this regard. And it offers me an opportunity, obviously, to do foundational work in terms of unearthing aspects that might be recommended for future use in research and interventions, policy, and service design. This is a map of a setting that I hope to do my study on. I know it doesn't tell you much. Johannesburg is a relatively small place geographically. It's divided into 7 regions. And in all of these 7 regions, there are a couple of townships. The purple, for instance, just show you how big Soweto is. Statistics South Africa, I think, informs us that there are about 6 million residents in the city of Joburg, and about 4 million of them are Black and probably Black African. And so it gives us a huge scope in which we could identify our participants. And so this study, as I said, will be done in 2 townships, primarily in Alexandra and another township in Soweto, but that does not limit me, just in case I need to go wider. Participants are Black African caregivers who are related to people who live with dementia, and it's important to mention that they have to live in the same setting, in the same homes as people who live with dementia. The group will include males and female adults who are carers, age 18 and above. And as I said before, they're related to living with a patient for at least a minimum period of a year. Exclusion criteria, there are a whole lot of professional trained caregivers, either trained in the private sector or public sector. Those are excluded in the study. And those who do not live in townships that I'm targeting, or part-time caregivers who probably just take about 2 to 3 hours looking after a person with dementia. In terms of sampling and recruitment, I have opted for the purpose of sampling to identify participants meeting this inclusion criteria. It's important because I want to target people who fit the characteristics of a target group that I'm aiming for. And recruitment will be done in multiple ways. So there's primary health clinics who might be seeing these patients from time to time in these 2 localities, and social workers as well who may be assisting families of people living with dementia. But I'm aware of 2 old age homes, one in Soweto and one in Alexander, who have a long waiting list of families who are willing to bring their loved ones into care because they are not able to cope with their loved ones, unfortunately. But also, I will go along to the neurology department of the Provincial Clinic Hospital. There's one popular, one called Shelf McCracken, which has a huge neurology department. There are NGOs as well, large ones, Alzheimer's South Africa, Dementia South Africa, and SADC, which are very important and may have a database of people who need help in this regard. Community radio stations are also a very good resource. Social media as well used. I'm not sure which ones in particular, but there's a whole variety that's available. Snowballing may be used, but I know this is going to be difficult since I said this target group is almost hidden away. They are marginalized. They might not know the next person. But I mentioned earlier that there was a study done in Soweto where a focus group was used. That might also be a resource where snowballing could work. And again, in terms of data collection and analysis, I am hoping to identify at least 15 to 20 participants in the study, and these are people who look after patients in their own homes. But again, this will depend by a point of data saturation. We don't have to go beyond 15. So we'll see how it goes. And interviews will be done. This is different. Interviews will be done in caregivers' homes in their preferred language. So data will be translated and transcribed. So there are dominant language groups in Soweto and Alexander, which is the Zulu group, the Sotho group, and in English, depending on how people feel. So participants who will be in the study will be reimbursed. Not that they've spent anything, but we are hoping to give out vouchers, 200 rand or thereabout. And a thematic analysis will be done using Brown and Clark's framework, which has proven to be very effective. And analysis will be done using the software and people. Ethical considerations, there's a lot I can say, but I'm just going to go very quickly through this. It makes sense that as we go into these people's homes and talk about this very important subject, it could trigger a whole lot of emotions. And for that reason, I've mentioned SADC, I've mentioned other organizations. Some people might prepare churches from which we might also recruit, so we will refer them to those organizations or any other organization that might participate in the study, which could take care of their mental health needs at the time. Data will be anonymized to respect their confidentiality, and data will be stored both physically and electronically by its password protected folders and also under lock and key. And the research team, which are my supervisors, will be the only professionals with access to this data. And required obviously guide and the UCT guidelines. And thanks to a competent team of my supervisors, and also the institutions behind the study. And as Mutalefa said, some of my colleagues said, they've supported us. We've been here for 3 weeks. It's not cheap. Thank you.
Deborah. So we're inviting Prof. Mark Schneider to come and give you some comments. The French colleague, CPMH for Life. Would you like to stand? The aircon or just...
Hi, Yvonne. Nice to meet you. I work with Roxanne on the Strike project, so I know passionate about it. What a little bit about dementia. Firstly, it's very nice to see the other end of the life was being represented in the study. And your study certainly has got a good structure, and I think you're well on your way to developing your full proposal. I do think it needs quite a lot of work on filling in the details mostly, and just thinking through some of the issues. I really like the inclusion of the social and spiritual, and I think that's an important one to look at and to understand, given that also often faith-based services are one of the key services that are provided. One of the things to think about is being careful about how you use terms. So in the title, you talk about family caregivers. In the proposal, you talk about filial and familial. Just take one. Family caregivers is perfectly fine. It's a kind of used term. Another one is needs and determinants. You didn't mention determinants here, but in the proposal, you talk about these psychological, social, cultural, and spiritual needs. And at some point, you talk about them as determinants. And I was thinking about it when I was reviewing it and thinking, you know, are they interchangeable or not? And I'm not sure that they are. I think we want to meet the needs in order for those determinants to become positive determinants, I suppose, in a way. So I think your proposal wouldn't really need to go into each of these 4 terms to really unpack exactly what you mean by them. So that will be quite a big part of your aspect. Objective 3 is around the health services that are available. And what you need to do is to think through whose perspective are you taking on that? Are you going to go and do an audit of all the healthcare needs, which may be a study in itself? Or are you just going to ask your participants, what do they access? Which may be, I think, perfectly sufficient for your purposes. What access do you have? You could do a brief review of what is available, but you need to define that objective a little bit more. I really want to know what questions you were going to ask. When you talk about semi-structured, and you really need to develop your topic guide, and you know, what questions are you going to ask to try and get to the spiritual needs? You know, what are you going to ask around that? Do you go to church? Do you belong to a church group? Do you get support from your church? Or, you know, do you belong to some other kind of spiritual group that, you know, what you get? And especially with dementia, it's about death. It's about moving towards death. And so it does raise lots of kind of spiritual issues around that as well. Just in terms of objective 3 in the health services, it might be useful to look a little bit beyond public health services. So given that social development plays such a big role, and faith-based organizations also, and any other NGOs in the area. I don't know if you happen to know in Joburg, there's old age homes, I think I've forgotten what that stands for, anyway. So, you know, do they provide respite care as a daycare center? Are there any of those around? Your recruitment, is the person living with dementia, does that person need to have had a formal diagnosis? Given that you may not find participants if that's your criteria, because it's such a complex differential diagnosis, and people may not have reached that point of having a full diagnosis. So think a little bit about, because dementia can be confused with so many other things, what are you going to use as a criteria to say this person that's being cared for really does have dementia? It's not other things. The long-term nature of it would be one thing. The inability to stay safely at home alone, those kind of things. And it may be useful to build a checklist to ask with either that has some kind of diagnosis, or develop a checklist that says, are these the kind of things that you experience, that the person is experiencing, that leads to the need for full-time care. So think a little bit more about that. In terms of the caregivers, it's also important to consider, what about in a family if it's shared, if the caregiving is shared? And you said you want them full-time, but what if there are 3 people that have effectively worked out a system of sharing the caregiving, which is actually a really positive thing? Would you exclude them? Just be very clear about exactly what your criteria are. You talk about outreaching on social media. I would be very careful about that. You only want 15 to 20. Given the growing need and the desperation of caregivers, I would be very careful about doing that. And that would be, I wouldn't even go that route actually, because you're going to get a lot you really don't know. You're not going to know.
Ashraf says so.
Right. I think those are some of the, also just potentially also administering a quick mental health screening instrument for the caregiver, just to give you something to hold on to. I think be careful about the adults population. There's a lot of political stuff around that. Yep. And I looked up the ranges. You say 750,000 to 1 million. I've looked up on internet 180,000 to 750. So there's just fair amount. Yeah, I think those are the main ones. I have sent comments to Kat and Claire, so they'll send them on to you.
Thanks very much for that. Those are very invaluable comments, well taken. I might want to speak to 1 or 2 of them, if that's okay. Okay, so the proposal has moved on quite a bit from the original one, not in the last few days. So you spoke about defining terms like filial and familial, and you also advised that we stick with caregivers, and that is still going to be outlined. But yes, caregivers is more general.
No, I'm talking about the family part.
Oh, okay.
You use filial, familial, and family caregivers. So I just choose one. Okay. And family caregivers is
sense. That's fair enough. And you also mentioned that there's, let me skip to objective 3, health services in particular. Which ones am I looking at? First of all, I wanted to constrain myself to just the Department of Health under the healthcare services in a locality. But it's important that social services is also considered. I've not thought about that. I think there are families who rely a couple of the time on social workers, and that could be also a source of either services or non-services. There's a lot that we can learn from there. In terms of recruitment.
Thanks, sorry, Ashraf said stop again.
Oh, I didn't. I didn't. Thanks for.
Thanks so much, Lebo and Margie. And now we have our final presentation for the day. It's Nicola Nkomba is presenting online. And we are going to advance her slides from this side. Nicola, are you ready?
Yes, I am. Can you see me? Can you hear me?
Great, we can hear you and we can see your slides.
All right, brilliant. And is this the Canva version, just before I start?
Kevin took the Canva version and transformed it into PowerPoint to try and keep the formatting for you. Is that all right?
The Canva version has some animations that help it flow a little bit better. So should I perhaps share my screen on this side?
Yeah,
Or
maybe
can
that's
we
better.
cast? All right, let me give that a go.
I'm just making sure that you've got permission to share.
Yes.
All right, you can go ahead.
Okay, I'm casting it. Almost.
All right, Nicola, you're able to see where to share.
Yes, I am. Just checking. Are you on the page that I'm on?
Yeah, we can actually see you on the screen. So
Okay. Perfect. All right. So let me get that into presenter view. All right. Okay, you can see the screen, right?
yeah, we can see the screen, not your notes.
Oh, okay, brilliant. All right, well, let me begin over here. Just get that into, yeah, there we go. All right, so I'm going to begin with a quote, and a quote merged into my acknowledgements. So the quote says, "Research is formalized curiosity. It is poking and prying with a purpose." And this is also just to say thank you to my supervisor, Prof. Desmond, Stellenbosch University, CPMH, and a special thanks to Claire and Kevin for making it possible for us to join online. So thank you so much for everyone that's made it possible for me to exercise my curiosity and to poke and pry with a purpose, which is my research topic. So I will be looking at the lived experiences of structural and interpersonal racism of Black women in relation to mental well-being, with a qualitative exploration on racism as a determinant of health. So looking at the literature, let's begin on the left corner over there in the pink. Interpersonal racism manifests when individuals' racial biases affect how they interact with other individuals. And then at a systemic level, racism is deeply woven into systems, beliefs, laws, policies, and practices that really reinforce and perpetuate discrimination. So the literature shows that racism is indeed a social and structural determinant of health. So just to clarify there that we're not setting out to prove that it is a determinant, but rather we are exploring that from the narrative and from the perspective of Black women within Southern Africa. And then interpersonal and systemic racism are shown to perpetuate mental health inequities and disparities. And this is the gap that I'm looking to address. I want to address the gap in representation of Black women in Southern Africa literature in relation to racism at the intersection of mental health. So looking at the study aim and objectives, my study aimed to build an understanding of the relationship between self-reported experiences of interpersonal and structural racism and the perceived mental health outcomes among Black women in Southern Africa. So I've got three objectives. First objective is to explore the perceived impacts of self-reported experiences of systemic and interpersonal racism experienced by Black women on their mental health. And then secondly, I'd like to investigate the relationship between structural racism and mental health outcomes among Black women within Southern Africa using narratives from Black women. And then finally, I'd like to explore how systemic and interpersonal racism can perpetuate disparities in mental health outcomes among Black women in the context of Southern Africa. So looking at the sampling and recruitment, I'm taking a purposive sampling approach, and phase one of it is through social media advert placements. So it's a pretty comprehensive step-by-step process. So firstly, social media advert placement will be put out. And this is also just to note that Facebook and other social media platforms that will be used, including LinkedIn and Instagram, they have their own additional ethical clearances or ethical ways of displaying adverts that will have to be adhered to. Otherwise, the advert won't be approved to go up. So just a footnote on that one. And then the social media adverts will be geo-targeted for urban and peri-urban areas. And this is really to increase the diversity in the socioeconomic backgrounds of a sample that is already homogeneous, as I'll be looking at Black women in particular. So the social media advert will contain a call to participate in the study. Sorry, that should have led to. Sorry about that. Let me go to the next slide. Okay, I am not able to have all the slides come up, but let me go on presenting. So in the second phase of the sampling, it's not even showing on the slide, is it? Sorry about that. Please excuse this malfunction, but I'll carry on talking about the sampling. So in the second phase of the sampling, which is, I mentioned there will be a call with an advert for participants to register. So after that, sorry?
Sorry, Nicola. I just want to say we've put the PDF up on our side because there did seem to be a problem with advancing the slides. So I'm trying to keep up with you, and I'm currently on sampling and recruitment with the.
Oh, okay, perfect. Thank you, Claire. So should I stop sharing my screen?
Yeah, I don't think we don't seem to be.
Okay, that's fine. I'll keep going. All right, yeah, so looking at phase 2, there will be a click to fill registration form, and this will contain characteristics such as contact details, but it will also contain a further description of the study, the work that's being done, and the context within which the study is being done, just to give the participants an extra added layer of learning more about the study so that they can truly provide informed consent. And then there will be a field within the form as well for consent to being contacted. And for those that do click on that field, they will be contacted by the researcher to get more study details, background, and to be screened based on the inclusion criteria if they do qualify. And then following that, verbal consent will be obtained. If they want to participate further, then informed consent forms will be sent through email, which should be signed before the interview. And all of these steps are being done in terms of the researcher contacting the participants beforehand to begin building rapport, even at the sampling stage, given the sensitive nature of the study, as it's looking at the intersection of two sensitive topics, racism and mental health. And then the total sample size will be between 20 to 25 participants. And this sample size will allow for data saturation to be reached and also to have a rich data set. So looking at the inclusion criteria, I'll be looking for women that self-identify as a Black woman, aged between 18 to 55, based in South Africa, access to reliable internet and a device from which they can interview, provide consent to participate, English speaking, and can provide self-reported experiences of systemic or interpersonal racism. Looking at the exclusion criteria, next slide. I will exclude participants that do not reside in South Africa, do not have access to internet or reliable devices, are under 18 or over the age of 55, and do not self-identify as a Black woman, and do not provide informed consent to participate, cannot provide self-reported lived experiences of systemic or interpersonal racism, and do not speak English. Next slide, looking at study setting. So the study setting will be virtual, and it will be carried out virtually in South Africa. South Africa, given that it's a country with a history of systemic racism. And this will be carried out via Microsoft Teams or a phone call, depending on who's able to access Microsoft Teams or who will have much more ease telephonically. Next slide, moving on to the procedure. So first things first, I will obtain ethical approval from the Stellenbosch University Human Ethics Research Committee. And following that, the interview schedule will be developed, and this will be piloted, given that we've got a sample of 20 to 25 participants. So the first few interviews, perhaps one or two, could be used to pilot and to see if the guide is indeed giving contextual answers, and then it would be adjusted accordingly for the remaining interviews. And the schedule development will be informed by a literature review and also looking at the race-based traumatic framework. And the interviews will be set for 1 hour to 1.5 hours. Purposive sampling, as I've mentioned before, is the method that we'll be using to recruit participants. So as I mentioned before, there will be a step within that purposive sampling, which will be to call and contact the participants and then to arrange a date and time that is most suitable, but also to carry on building rapport and to prepare the participants for the interview, letting them know what to expect, and also letting them know to be in a private room to uphold their confidentiality and their privacy. Next slide, which is procedure continued. So the interviews will be carried out, as I mentioned before, digitally on Microsoft Teams or phone call. And at the beginning of the interview, to further build rapport, there will be an introduction again by the researcher, and the researcher will go through the informed consent process just to ensure that the participant is aware of the study, and also just so that they can provide informed consent. They'll be allowed to ask any questions for clarity, and then once they give verbal consent, also this is verbal consent upon receiving the informed consent forms, then the data collection will begin. The data will be recorded both on Teams and an audio device as a backup, but also for those that will be interviewing telephonically. And it'll be stored securely on a password-protected laptop. And this will be password-protected laptops for the entire research team, but also with a backup folder stored up in some type of cloud drive, which is also password-protected. And then thereafter, the audio recordings will be transcribed, preparing for the data analysis process. I'll use TurboScribe software to do a verbatim transcription, and this will be quality checked by a research assistant. Next slide, moving on to data analysis. I'll be applying Braun and Clark's 6-phase framework. So data familiarization will be the first step, generating codes, sorting through codes, reviewing themes, defining and naming themes, and then doing the write-up. I specifically mentioned some areas there, like generating codes and sorting codes into themes, as areas that will require the support of a research team, in this case, research assistant, but also with the supervision of my research supervisor. And this is to address the issue of reflexivity, this is to address any issues of bias that may arise. So I would take this approach to generate initial codes separately with the research team so that we can triangulate the findings from the investigator, the key researcher, but also the research team, just to lessen our chances of bias. And I'd mentioned before, I think in the previous slide, that there will be a reflexive journal kept. And at this point in the thematic analysis is where this will be shared with the team so that they're also aware, as we are generating the codes and generating the meanings, some biases that the researcher might be predisposed to, and so that those biases can be interrogated. Moving on to ethical considerations, the next slide. So I talked a little bit about informed consent all throughout, but just to reiterate, this will begin at the sampling process. So if you remember, I mentioned earlier that even to contact the potential participant, they will have to consent to being contacted by the researcher. So it begins there. And then followed by that, informed consent form will be sent after the screening call with the researcher and revised before the interview. And then verbal consent before the interview will be provided as well. In terms of confidentiality, pseudonyms will be assigned to the participants and their data records, and also data storage will be on password-protected devices backed up in password-protected cloud folders, and the interviewees, or the participants rather, will be advised to take the interview from a private room, and they'll be informed also that the audios and the recordings will be deleted after the study is completed to maintain their confidentiality. And then non-malfeasance. Sorry?
Thanks, Nicola. Sorry, we've run out of time. You've given us a beautiful overview of your study and a lot of nice detail. The last slide was thank you anyway. So I'm really sorry. Ashraf said we had. All right, and now I'm going to invite Prof. Ratel from Stellenbosch University, who's going to come and sit where I'm sitting so you can see him and give you some feedback.
I don't think,
All right,
I don't know what.
Do you want to come to see her? She's
No.
on the screen. Right.
No.
Look at.
So racism and Black women, I mean, we should have hundreds of these studies. I think Desmond and Nicola would agree. So I absolutely love that you're doing this work. Desmond, racism. I would suggest first drop in the subtitle there. It's redundant. And then this word lived experience is as Leboham or somebody, person who just presented as well, and I've seen it in several. What does that mean? I'm being a pageant here. I like this word, lived experience. Is it experience? Nicola doesn't offer an explanation of this. Is it phenomenological? I mean, does it come from that? Is it Fanonian? What are we talking about? Can you have experience without lived experience? Can you have lived experience different from experience? So clarification of that, that's my thing. And so I'm also suggesting perhaps a little bit of theorizing of what you mean by lived experience. Because then you'd have to ask the people before you ask them whether they've had this experience as a lived experience before you get into the study. You tend to speak about structural and systemic racism as one thing. So for instance, in your study aims, at the top, you say structural racism. But when you ask you are systemic racism, are these the same thing? Are they if they are, then you want to use them consistently. Systemic / racism, or you stick to one. So just consistency. Because some people define it differently. And are they the same as institutional level racism? Third point is about framing theory. So you spend a lot of time when you were presenting on what you had written about, which is procedure, the recruitment. You didn't say much about then you have a little background, a shorter background and rationale of the study. So you don't have a literature review. I suppose this will come at some point. So that's missing. And then when you state your aims, you start by saying something about trauma theory. And this is the first time we see it. So either you're going to say it in the literature review. And like Ashraf was saying, I am a theory buff. So I love hearing people doing empirical work. I just love because it's like a gold dust to me. So perhaps but I still would like to see a section on framing theory. Again, it could be about lived experience or even about trauma theory. So you're missing the framing theory, you're missing the literature review. I'm a little not concerned, but the recruitment might funnel your study toward a particular subgroup of Black women. So these are, you said up to 55, 18 to 55, and you say something about the 18 to 35 active users. I think 18 to 55 is too broad. Perhaps you want to narrow it, because the younger population, as far as I know, tend to be much more active than the older ones, but also they're online. So they have particular kinds of experiences on racism. There's a book in South Africa that came out 2 years ago called Black Racist Bitch or something like that. So she's talking about a specific kind of thing that happens online. So your study might be about people who participate online, and that might be to be clear. Last one, I said age range. I have made annotations in the documents. I'll send them to both of you and to Desmond and to Claire as soon as I get home. So this is a good study. It needs a little bit more fleshing. Vigorously, energetically encouraged that you do it. So thanks for the work here.
Thank you. Thank you so much for the feedback. I think there's a lot there that I need to just see how I'll work it back into the study, like the framing theory, for example. That's really good feedback, and I'll work with my supervisor to see how we can bring that to life in the study. And then with regards to the recruitment, I'm just thinking in terms of the age group, I might have missed the question, but then I can just iron that out a little bit more in terms of how I want to frame it in the recruitment process. So I want to diversify the age groups, to diversify also the experiences that we'll be looking at. So what I can do there is that depending on the social media platform, seeing which demographic is the most active per platform, I can specifically tailor adverts to the different age groups. So for example, you find younger people are the ones using Facebook and Instagram, and then on LinkedIn, I find more working people and older generation. So that's something that I could do there just to, I guess, yeah, make sure that the age groups being reached are the appropriate ones and on the appropriate platforms. So I'm not sure if that's how I was understanding it, but that's my response to that. And then in terms of the lived experience, thank you for that. I will clarify that bit and once again, theorize that lived experience bit. And I've also taken your point on keeping it consistent, whether it's systemic or structural racism. So it's very helpful feedback. Thank you so much.
Great. Thanks so much, Nicola. Let's give her a round of applause.
Thank you, Claire. And thanks, everyone.
Yeah, it's a really good study, and obviously you're going to have a lot more good discussions. I was very glad to hear that Facebook is for that younger crowd as well. My son's told me that Facebook is for old people. I really appreciate that information. All right, so it's been a wonderful morning. Our MPhil students have really done us proud. There's obviously lots of layering and theorizing and lots more discussions. So it's just the start of the MPhil journey. And I look forward to see how all these studies pan out. Now I'm going to hand over to Ashraf, not to stop us, but to close off.
Okay, so it's my job to bring these proceedings to a close. I'm sure you can all agree that we've had a wonderful morning of wonderful intellectual conversations about methodology and ideas and public mental health. So thank you very much indeed to the MPhil students for your excellent presentations, for putting the effort and energy into them, and for creating this intellectual atmosphere for us. Thank you to the supervisors. I know there wasn't that much time. 3 weeks is very little time to work with a student to get them to this point, but I think we can all say that we've done good work, and we should be proud. And then thank you very much to the reviewers who put a lot of effort into providing feedback, very thoughtful feedback as well. I want to say to the MPhil students, please do finish this degree. We will support you through that build. We exist here to support you and to make sure that you graduate. We want you to potentially come back for a PhD, but also to go out into the world of public mental health and make a contribution to society with the skills that you will have. And do stay in touch. We need colleagues on the continent, in the country. We need potential supervisors, co-supervisors for our future MPhil students, and we'd like to perhaps call upon you in the years to come. So please do stay in touch with us, and we want you as colleagues, we want you as friends, we want you in our community of public mental health researchers.